Good afternoon to you all, dear esteemed guests, respected colleagues, and distinguished members of ISPAT. On behalf of Indian Society of Prenatal Diagnosis and Therapy, I extend a warm and heartfelt welcome to each of you for today's webinar on integrated genomic testing as standard of care in obstetrics. It is an honor to bring together experts, practitioners, researchers, and advocates in the field of prenatal care and genetic counseling to share knowledge, innovations, and ideas that will help shape the future of prenatal diagnosis in therapy in India and beyond. With that, I welcome up Honorable Secretary General of ISPAT, Dr. Manjeet Mehta, who has overall experience of 32 years in genetics in India, UK, and USA. She has a PhD in human genetics from Just Look, Mumbai, and two postdoctoral fellowships from Toronto and London. Ma'am, please, I welcome you for the welcome address.
Thank you for this, Dr. Maria, and a warm welcome to all of you. Good afternoon, dear esteemed colleagues. It is an honor to see the amazing response of this gathering of obstetricians, geneticists, people in the fetal medicine space, all of them united by a mission to advance maternal and fetal care. Recent advances in genetics have unlocked new possibilities for precision medicine in obstetrics. Genomic testing allows us to move beyond the traditional diagnostics to detect and to manage genetic anomalies early. Tests like NIPT, carrier screening, PGT are revolutionizing our ability to identify risks and to tailor interventions. And the increasing use of genetic tests, it helps us for identifying a high-risk pregnancy early, therefore enabling a timely intervention to personalize care plans and tailoring the monitoring and the treatments given to them. We can give appropriate counseling, providing actionable insights for families, and ultimately improve the outcomes by proactively addressing the risks to enhance the long-term health. As many of you would know, ISPAT, which is the Indian Society for Prenatal Diagnosis and Therapy, has been pivotal in spreading genomic knowledge across India since 1989. Having started 36 years back, we are the oldest organization in India in the space of fetal medicine. We at ISPAT regularly organize workshops, conferences, training programs to ensure that the practitioners stay updated and equipped to apply these advancements effectively to ultimately elevate obstetric care and reaffirm our commitment to maternal and fetal health. I would urge you all to visit our website, ispat.org.in. If you're not yet a member, become one today and join this huge family of like-minded professionals in the space of preconceptional, prenatal, and neonatal medicine. With these few words, I welcome you all to this wonderful webinar that we have planned today. There are some really amazing and interesting cases that are going to be discussed. So stay glued to your seats, for this is going to be a wonderful experience. Welcome, everybody, and I open the webinar. Back to Bhavya, please.
Yes, ma'am. Thank you, ma'am. So I also want to introduce my co-moderator, Dr. Vidhu Dhawan today, who's MBBS, MD, and PhD in molecular reproduction and genetics from AIMS New Delhi. She's ex-faculty AIMS New Delhi and consultant genetist at Zagin Health. With that, let me first invite our first speaker for today, Dr. Minakshi Lalla. She's MS Gynae, DM in medical genetics at from SDPGI Lucknow. She is clinical geneticist at Prime Imaging and Prenatal Diagnostics, Chandigarh. Ma'am has a lot of interest and she's very keen with her research work. She has won Best Oral Paper Award in UA Foxy 2013 also. And today she will be talking about genetic testing in obstetrics, when to order what. So ma'am, I welcome you here to share your insights on the same.
Thank you. Thank you for the kind introduction. And I'll be just, I think you'll have to, only one presenter can share, no? So you'll have to close
okay,
this.
Okay, ma'am, I'll stop sharing. Yes, ma'am.
I'll share mine. Thank you. So I hope my screen is visible. I'll just stop my video so that, sorry. My screen is visible, I hope. Shall I start?
Yes, Dr. Meenakshi, you are visible. Your screen is visible.
And I'm audible. Thank you so
Yeah,
much.
audible.
So, my topic is genetic testing in obstetrics, when to order and what to order. So, we obstetricians, the usual OPD scenario for genetic counseling and testing in our OPDs is that we see a lot of patients who have advanced maternal age, where the dual, triple, I should not say triple because it's really outdated, quadruple or the NIPT testing is about to be done or has turned out to be positive. The second is when we are presented with a fetus with abnormal malformations, structural malformations, either in the first trimester or the level 2 scan or in any of the later on scans in the previous coming trimesters. If a fetus has some markers of infection, or if there are any drugs intakes, any carrier screening positive, especially thalassemia is a common one, or any untoward previous histories. So we know when we come across this, we know then we are looking at some genetic maze. Genetic testing is a maze, I would say, because there are so many number of genetic tests that are available, and it seems like a genetic jargon to the regular practitioner. There is karyotype, then there is microarray, then there is a high resolution microarray or a low resolution microarray. Then there are certain tests: FISH, QFPCR, NGS, exome, Sanger, genome. So what is all this going on? So we're just going to have a bird's eye view of all of this testing. So the thing to always remember is that genetic etiology has to be identified, and genetic testing should always be based upon the genetic etiology that we are trying to find out. So we cannot order a karyotype when I'm thinking of a thalassemia patient, or I cannot order exome when I'm thinking of Beckwith-Widman. So I need to know what I am thinking of, what my probable diagnosis is, what is the underlying genetic etiology I am thinking of, and then I have to send my targeted genetic testing. So aneuploidy or a copy number variation, which are chromosomal disorders, will have a different set of genetic testing. Single gene defect will have a different set of genetic testing. And there comes in the role of play how much gene is covered in which test. Methylation disorders will have a different genetic testing. Infectious, the PCRs are going to be different. And here comes the role of pre and post test genetic counseling, especially for tests like next generation sequencing, where we can get no results, VUS results. Sometimes you might have to test the parents. So all this should be sensitized to the patient before. So the pre and post test genetic counseling is important. So just a quick view of what the genetics is all about. So if we compare to a book, then there are pages in a book, and then there is the text in the book. So if you're looking at the book completely, that means one book is one chromosome. So you can look at the book by means of chromosome as well as a microarray. If you want to look at the details inside of the book, page by page, details inside the chromosomes, it can be done by microarray, FISH, MLPA, but they are targeting different regions. Microarray is genomic, FISH and MLPA are targeted. Then, if you have to look inside the fine print on each page, then there is something called single gene testing by means of, NGS, exome, or Sanger sequencing. So this counseling and our knowledge of this will help us, to know which tests has to be utilized where, the uses, limitations, pros and cons. So for Down syndrome, I will not order NGS or a panel. A simple karyotype will suffice. So if I'm thinking of a 22q microdeletion, a microarray or a targeted FISH or MLPA might help. And if I'm thinking of skeletal dysplasia phenotype, thalassemia, cystic fibrosis, then I might want to look at the panels or the exomes. So what different tests can we do? So for chromosomes, a karyotype, a microarray. For the small copy number variants, again, this has been we just discussed. And for the small finer print inside, Sanger, NGS, exome, genome panels. So this just shows us the outline of the genetic testing in obstetrics. So we see patients who come to us for carrier screen, prenatal screening, prenatal diagnosis, CVS and amnio, postnatal samples we get, and we also see patients who are not pregnant. They've come us either for infertility or recurrent pregnancy losses. So in all these scenarios, genetic testing is utilized and effective for prognostication and for reoccurrence risks. So preconceptional carrier screening, I will not go into the details. We have a very good talk for the in the next few minutes for this. So, but we know it's to be recommended, and there can be not one single test for screening also, because thalassemia you can very easily do it with HPLC. SMA will require a PCR or MLPA, sometimes Sanger, not going into the nuances. So, see, one test is not covering it all. Fragile X, a TP PCR or Southern blot, and for CAH and expanded carrier screen, so NGS. So, it being costly, there is not one single test that is going to cover it all and cover it all completely. So, we need to know that one single test cannot look for it. Each test has its own limitations, yields, and strengths. Second is the very common scenario we come across when the patient comes to us with prenatal screening results, down screening positive, or some ultrasound malformations. So, NIPT, we are very frequently ordering. We know that it is very good for trisomy 21. It has a sensitivity of 99.6%. We can get false positives in case there is a vanishing twin, there is confined placental mosaicism, some maternal malignancy, mosaicism, or fetal chromosomal rearrangement. False negatives can be there, which we should always counsel to a patient. It is NIPT is just a screening test. So there can be a no call, and if there is a no call, we know that we might have to proceed for amniocentesis. So this should be explained beforehand. And NIPT is not a solution to all the genetic problems, because patients will frequently come to you, why is this thing coming? We've already got our NIPT done. No, but NIPT is very sensitive for trisomy 21, not even 100% for that. So if we get NIPT, what to do when we have NIPT high risk? What genetic test to order? So I would advise, if you have a high risk for trisomy 13, do a very good ultrasound, phenotyping of the fetus. Then what to do? Either a CVS or amniocentesis. Amniocentesis better, because we want to rule out the mosaicism, which is because sometimes there can be mosaicism in the CVS samples, and fish, because QFPCR might not be very good for the picking up mosaicism, and karyotype we want to see because it is also better at picking up mosaicism as compared to microarray. So here we see that the different, routinely we are doing QFPCR and microarray when we are doing amniocentesis, or fish and microarray, but here the tests will change because our indications are going to be changed. So we want to know that yes, in trisomy 13, 18 and other things, mosaicism can be important, and in sex chromosomal disorders also. So that is why we want to shift our gears from microarray and QFPCR along with to fish and karyotype. So, and what about the upcoming thing in NIPT? Should we be looking for all these deletional syndromes? Should we be looking at all the chromosomes? Probably no, as of now, routinely, because the false positive rate is higher, and routinely it is not recommended. So if you have multiple malformations coming, minor or major, in your level 2 scan or in the level 1 scan, the NT-NV scan, the invasive testing is a better testing along with chromosomal testing by microarray and DNA storage, and rather than an extended NIPT as of now. So advances in NIPT, again, the same thing. The rare autosomal trisomies, what will we gain by looking at all the other chromosomes if the ultrasound looks okay? It will have high false positive rate. So you will increase your rate of amniocentesis and the stress to the patient. So rare autosomal trisomies, we should not be looking at routinely in the NIPT. So microdeletion, copy number variation, yes, there are certain instances where you might want to look at them non-invasively, but as of now, I would counsel my patient that amniocentesis will have a better yield if the need be to look at all these things, because it can be false positive and then go to NIPT, or the smaller regions, the extended NIPT will not even detect, it will miss. So when to order NIPT? Of course, it is the best screening method. We counsel every patient. So if they opt for it, why not? That is what the ACMG and ACOG say. In advanced maternal age, when there is biochemical screen risk is high, or when the parents test. When not to be done, if you see a structural anomaly, major or many minor in ultrasound. So it's important to phenotype that fetus and do an invasive test. When NT is high, when the patient characteristics, the very high or abnormal biochemical values, a bone marrow transplant patient, when you're near 20 weeks, because the sequential testing might take you away from that 24-week periods, and if there is some family history which you want to rule out by certain genetic testing. So it's always a good practice to do NIPT after your NTNB scan is normal. There is no upper limit though for it. The third scenario is when the patient is actually coming to you for a prenatal diagnosis and you're doing either a CVS or amniocentesis, then what tests are you going to order in those conditions? So if it's aneuploidy screen positive, so a routine QFPCR and microarray is the thing that we usually do. In advanced maternal age also same, but if there are multiple soft markers, if it's unossified hypoplastic nasal wound, I routinely would prefer my amniocentesis over NIPT because certain copy number variations cannot be picked up by NIPT, which are seen here. And ventriculomegaly, as we'll see in the coming case, there can be many things which can be missed by the simple NIPT or a simple QFPCR and microarray. So phenotype your fetus well, it's isolated in multiple, what is the growth, and then decide the testing. So chromosomal tests include the rapid aneuploidy test, the QFPCR, FISH, MLPA, and genomic means they are covering all the chromosomes. They include karyotype and microarray. Even the low pass genome sequencing has come up now. And but always do one thing: when you get these reports now, or when the people visit you, ask them what is the resolution, what is their labs cutoff. It is 1 MB, two. I've seen even 2 MB, 500 MB. It is 500 KB or 1 MB, 2B. It is very important because if it is a very large cutoff, you will miss the smaller regions. So a microarray is very good because in those that regions are enriched. But now with whole genome pass sequencing, if they're taking very large cutoffs, these can be missed. And it's always good to have a DNA stored backup in the lab if you're seeing something other than which is aneuploidy positive. So NGS in obstetrics is very much coming up now. We are doing so many fetal exomes on a daily basis now. We are sequencing the genes. When we see a skeletal phenotype, we are looking for skeletal dysplasia genes. So what are these? There can be a specific panel like a rasopathy panel, or it could be a skeletal dysplasia panel. There is clinical exome when you are only sequencing the 8 to 9,009 genes. So the genes included will vary with the different providers also. It's a whole exome where you're doing all the protein coding region, or it's a genome, then you're sequencing everything. So whenever you see and whenever we have to send NGS in our practice, it's very important to have a pre-test genetic counseling because this test is not very simple. Because there is a large amount of data that is generated, it has certain limitations, pros, cons. It is very phenotype based, what information you give. There are certain findings called VUS, uncertain variants that you can get. So it should be sensitized to the parents. What is the turnaround time of this test? It's a solo fetal exomes. I would really discourage the solo exomes because then how do you know what you're getting is a new mutation or it's inherited from the parents? So trios are always preferred, but we know that the cost limitations sometimes force us to send solo exomes. So also if the patient is coming to you, then there is a previous child with thalassemia. I know that if I know those thalassemia mutations, I will simply send the same in this patient. In this fetus, if there is a patient previous child with something like Williams syndrome, I will look at that region in my microarray in this fetus. If it's a previous child with DMD, I will do MLPA DMD. If it's a previous child with some glycogen storage disorder, I will do NGS or Sanger. So the previous fetus workup is very, very important, and we do need some time for that. So it's very important to refer those patients for genetic testing and counseling in the first trimester, or best time is pre-pregnancy, because then we can discuss with them the other reproduction etiologies as well. If the child has not been worked up, it's very important. And patients do ask us, oh, it's going to cost a ton. Why don't you test my fetus directly? No, that is not going to give us the complete answer. And it's not even legally correct. We should not be testing the fetus directly without testing the proband. Or if the proband or the index is not available, test the parents. So the common scenarios are if you're getting increased NT or NF, I have to look at the chromosomes. I can do it by a microarray or whole genome low pass, or monogenic, we do the next generation sequencing. Then multiple soft markers, depending upon the soft markers, I test my, I choose my test. If it's an omphalocele, ecogenic kidneys, placental mesenchymal dysplasia, I want to add for Beckwith-Widman, MSMLPA. This is one just addition I'm telling. There are many other specialized tests also which we can add, like Fragile X, there is TPPCR, See, like this fetus had only a borderline 10 to 11 ventriculomegaly, but we found out a pathogenic mutation. And here, a trio is best because it was seen de novo, so it gave a quick diagnosis and not much weight beyond the legal limit of 24 weeks. So this fetus has a pathogenic and an uncertain variant. Now here it's important to work up the parents. A trio would have really helped here, but unfortunately they opted for a solo due to cost constraints, and then we had to go back and test the parents, which took time. So all this needs explanation and workup. The second last thing would be the postnatal samples that we get, missed miscarriages, abnormal fetuses which we abort. So PSC, product of conception testing, is very important because those cases in we can get if it is what's the recurrence risk. Like here it's trisomy 18. I know the recurrence risk is less than 1%, but here the second report shows a segmental duplication likely in one of the parents, and the recurrence risk would be around 50%. So for those, based on the POC testing, the risks have changed. So the POC less than 10 weeks, we would want to test by a microarray or a whole pass genome. Karyotype usually fails, and FISH QFPCR, extended QFPCR, give us limited coverage on the chromosome, so I would avoid those also. A whole genomic approach by microarray or a low pass genome is best. So fetal autopsy is very important because the fetus gives us more phenotype which cannot be seen by ultrasound. It gives you, especially if you have VUS results, you can look at the fetal phenotype and decide. DNA can be stored if you're going for stepwise testing. And fetal autopsy is underutilized but very important. Then if you have a male coming with infertility, what is the routine genetic testing that we are advocating? So a karyotype, definitely karyotype in male and female infertility, Y chromosome microdeletions, and if it is an obstructive type, then we would want to, if it is if it is obstructive type, then CFTR, single gene defects, hypogonadotrophic hypogonadism. And so these routinely we are going for karyotype, microarray, PCR, and MLPAs. And so routinely karyotype, so semen analysis picture is very important to decide the genetic testing in male infertility. Female infertility, a karyotype is definitely must because we do have mosaics for Turner. So sometimes fragile X premutation carriers are there. And if it's hypogonadotrophic hypogonadism, we want to look at those genes as well. And sometimes AR gene and premature ovarian failure cases. So it depends upon it. The yield is lesser as compared to male infertility, but still important to test these patients. Recurrent pregnancy loss is a big enigma. Genetic causes are 5% and they are growing. It could be a de novo trisomy in 16, 18, or 4, and it's resulted in pregnancy loss. These are, it's important to test them because they will be de novo and not reoccurring. If it's a balanced translocation, it would be a POC directed if you come to know it. Then depending upon the parental karyotypes, it will reoccur in 50% cases. Histopathology important because there can be sometimes recurrent molar due to maternal NPLR3 mutation. So recurrent molar, so you have to go for ovum donor or certain early embryonic genes. So parental karyotype routine in recurrent pregnancy loss, POC testing is definitely microarray. NGS has a limited role. You really have to counsel about the yield before going in for that testing level. So at the end, I would really like to thank all of you. And I know genetic testing is a maze, but from running from genetic tests, we have to embrace the testing because that's the future and it solves so many dilemmas and things in the patient's life. So thank you, everyone. So I'll stop sharing here.
Thank you, Dr. Meenakshi, for a very nice talk of yours. You elaborately have covered all the aspects of the genetic testing, catering from the recurrent pregnancy loss, what all testing would be required in from the antenatal to all the testing that would be needed further. I would urge all the speakers to put their questions in the chat box. And before we move further, we very pertinently actually had missed introducing our first moderator, Dr. Bhavya Doshi herself. I would like to introduce Dr. Bhavya on the same note here. And before we go further, Dr. Bhavya Doshi is a consultant gynecologist at Apple Hospital, Indore, and with fellowships in high-risk pregnancy and also in endoscopy from Maharashtra. She specializes in high-risk pregnancy and minimal invasive surgeries. On that note, I really request our participants to please ask their questions. I would now like to introduce our next speaker, Dr. Meenal Agarwal. She's the Director, Clinical Genetics at MedGenome Labs, and she's also next faculty at SGPGI Lucknow. And her areas of expertise are performing and analyzing the interpretation of various reports, and she has various publications to her credit. Over to you, Dr. Meenal Agarwal. We look forward to hearing you. I again, before Dr. Meenal starts her presentation, I again urge everyone to please put their questions in the chat box or note down their questions, which can be taken up later.
Thank you,
Dr.
Dr.
Meenal.
Vidhu. Thank you, Dr. Vidhu, and thank you, ISPAT, for giving us this opportunity. Let me put up my presentation. 1 second. It is not allowing me to put up my presentation. It is showing only one participant can share.
They will have to stop sharing, Dr. Vidhu.
Yeah. Can you see my screen now?
Yes, yes.
Okay.
Make it
Let
full.
me see if I can make it full. Yeah. Somehow I am unable to. Is it okay if I go like this? Because, yeah, I can see now. Okay. Okay, can I go ahead, Dr. Seema?
Yeah. Go ahead.
Okay. Okay. Thank you, Dr. Meenakshi, for making my job easier. You have given the wonderful outlines of genetic testing. So some of my slides and content will be overlapping, so I will be skipping them. So in next few slides, I will be kind of talking what is a carrier screening, what is a reproductive, why do we need to test it, when do we need to test it, and what kind of testing and for which disorders we should be testing. So just a quick overview. I mean, all of us or human beings are developing from the union of two cells, one sperm and one egg. And at that union, at the zygote formation, all our fate is decided and fixed for our lifetime. And at that point of time, half of the genetic material comes from each side. And that half of genetic material is 23 chromosomes and one copy of about 20 to 25,000 genes. So each one of us pass only one cell to our offspring. And even if family history is normal, even if the family and the marriage is not among relatives, the pregnancy is at low risk, then also there is a background chance of 2 to 3% of any genetic disorder in every pregnancy. And I tell always my couples and families who come to me for counseling that there is no perfect genetic test which can be done pre-pregnancy or during pregnancy, which can predict or diagnose all possible genetic disorders in the offspring. But carrier testing is something where this risk can be minimized to a significant level. So what is a carrier? As I told, and Dr. Meenakshi also told, that we all are carrying about 20 to 25,000 genes in our each cell. Apart from the genes located on X chromosome, one copy of these genes come from father and other copy of the gene comes from the mother. So if someone is carrying a variant, which is previously known as a mutation, for a recessive condition, like a X-linked recessive and autosomal, and I will be talking about these in next few slides, only one copy of the gene is abnormal, the second copy of the gene is working normal. So in that case, the person is having one working copy and that is a carrier. And because one copy is working fine, they are usually asymptomatic. Each one of us in the world are likely to be a carrier for 2 to 3 genetic disorders, and carriers are asymptomatic generally for their lifetime. But if by chance two carriers marry to each other, there is a chance that abnormal copy of the genes can be inherited from each parent, and the future offspring may be at higher risk for serious genetic disorders. And that's when we talk about carrier testing. For understanding carrier testing, we need a minute to understand a recessive and a dominant disorders, mainly in the autosomal context. So we know that we have 23 pair of chromosomes. 1 to 22 chromosomes are called as autosomes, and XX and XY, depending upon it's a male or a female. If there is one abnormal copy is enough to produce a disease, it becomes a dominant disorders like Marfan syndrome, neurofibromatosis, tuberous sclerosis. And there is a 50% chance of transmitting this gene and thus this trait to your future offspring. In the recessive disorder, however, we need to have both the copies of abnormal gene for the disease to be manifested, and ideally one coming from each parent. And if the carriers for the same gene marry to each other, their offspring has 25% chance of getting both the abnormal copies. And the examples of these conditions are thalassemia, cystic fibrosis, most of the metabolic disorders, spinal muscular dystrophy, and so on and so forth. X-linked disorders are a little different because males have only one copy, they are XY, and females have two copies of X chromosomes. So generally for recessive conditions, females are asymptomatic because they are carrying one normal copy of the gene. But if they pass that copy, abnormal copy of the X chromosome to their son, that will be affected because they will have only the abnormal copy of X chromosomes. So generally, if a lady is carrying a X-linked recessive disorder gene, there is a 50% chance of having affected sons, 50% chance of having carrier daughters, and typical examples are DMD and hemophilia. So what is the carrier screening testing? So as the name says, carrier, we know now, is screening that because we are doing this test in the asymptomatic populations and many times without any risk, without any family risk or specific risk, it is done in one or both reproductive partners to identify the risk for a particular or a few genetic diseases in the future generation. So this is a screening test which can be offered to asymptomatic people, one partner, and ideally it should be done in both partners. There are typically three types of screening tests which are commonly talked about. One is universal screening test, which is very much similar to a screening during pregnancy for aneuploidy, whether you offer a dual marker test or a quadruple marker test or NIPT. This is a screening test which is offered to generally all pregnant women in India. So universal genetic screening test is also recommended for all couples. And across the globe, this depends upon the geographical location and ethnic origin. And for Indian scenario, which conditions are recommended for a universal screening, I will talk about. Second, there is an expanded screening test where you are doing genome-wide test like clinical exome sequencing. For many more genetic conditions, it may not be for all 7 to 10,000 genetic disorders, but a few curated genetic disorders which are early onset and severe conditions. And it also depends upon the family history, cultural preferences, and the geographical location guidelines. Third kind of screening can be a targeted screening when you have a family history of a genetic disorders, which is covered in a specific type of genetic test, like Dr. Meenakshi elaborated, that all kinds of genetic testing, genetic diseases cannot be covered by a single test. There are few specific tests for genetic conditions, and if there is a past bad obstetrical history, and I will talk about these examples in a minute. Then the second question comes to its why carrier screening. And as I've been telling that there is, each one of us is a chance that we are carrier of 2 to 3 genetic diseases. These individuals are asymptomatic. We might not have any family history, but if the two carriers marry who are carrier for a common genetic disorders, their future generation, their offspring are at risk. And even if without family history, their first child can be affected. The purpose of carrier screening to identify those couples who are at risk, so their first affected pregnancy can be stopped from happening, or maybe we can offer them a prenatal diagnosis. And it is important to know that more than 80% of babies born with genetic diseases have no family history. So even if family history is normal, we have to offer this carrier screening. Then who should be tested? And as I've been discussing, it has universal screening test has to be offered to every couple. An expanded carrier screening for lot many genetic disorders can be offered to a specific group of individuals, like a family history, consanguineous family, bad obstetric history, unsatisfactory reproductive outcome. But it also depends upon the family values, beliefs, their preferences, and their country-specific guidelines. When should be tested? As Dr. Meenakshi also elaborated, genetic workup takes time. Especially these kind of advanced genetic testing may easily can take up to 1 to 2 months to plan the testing, to understand the testing results and the pre-test and the post-test counseling session. So ideally, it should be done in a preconception phase before planning pregnancy, or as soon as they stop using contraception. And early pregnancy as 6 to 7 weeks is also suitable. But if the couple comes late in pregnancy, we have to go with a little caution and doing all the counseling measures. So another question is for which condition? So universal and expanded. So universal screening, as I said, depends upon the specific geographical location and country-specific guidelines. And I'll talk about the specific guidelines about India. American College of Medical Genetics talks about tier-wise screening based on the carrier frequency in the population. So it ranges from universal to tier 2, tier 3, and tier 4, depending upon the carrier frequency. But because the carrier frequency for all rare genetic disorders are not available in geographical population, most of the scientific community, they are inclined towards an expanded carrier screening testing in certain scenarios. So this is the guidelines which was given by American College of Medical Genetics. And as I said, there is no prevalence estimates available for most of the genetic disorders, and there can be cultural, social, and financial differences as well. So last year, 2023, IAMG with FOXY, with Society of Fetal Medicine, they have released a carrier screening guidelines, and they recommend that all Indian couples have to be offered a universal screening for spinal muscular atrophy and beta thalassemia. For spinal muscular atrophy, the ideal test would be an MLPA test for SMN1 gene, which will detect 97 to 98% of carrier states. For beta thalassemia, a combination of HbA2 estimation by HPLC and red cell indices are recommended. Expanded carrier screening in certain scenarios and only after consultation with medical geneticist, and the pre-test and the post-test counseling is must. This I will skip. It is just to let you know that how the genetic testing refer, the kind of camera, the kind of the disorder you want to look at, and the resolution you want to look at. And there are so many platforms, and each platform has its utility in the carrier screening. All these molecular tests, they start from DNA, but what test you choose is important, and it depends upon what kind of genetic testing you want to screen for. So genetic disorder can be divided into the chromosomal or single gene disorders, multifactorial disorders like diabetes, hypertension, and there are some mitochondrial and triplet repeat disorders as well. So currently, as of now, carrier screening is not recommended for late onset or multifactorial disorders. And I will talk about the chromosomal and single gene disorders. So how do we test for these disorders? As I've been speaking, depends upon condition, type of genetic test, and best platform. So if the couple comes to you for infertility, recurrent pregnancy losses, unexplained IUD, couple karyotype has to be done for balanced chromosomal rearrangement, because this is something which will not be seen in any other test, even in the advanced genetic testing. Thalassemia we have already spoken about, SMA we have already spoken about. The carrier testing for a fragile X pre-mutation carrier and CYP21A2 associated congenital adrenal hyperplasia, currently not recommended as a universal screening test, but when you see recurrent implantation failure, infertile couple, you may opt for fragile X pre-mutation carrier status. And if the family history is suggested, then CYP21A2 related genetic defects. But remember, this has a specific test for a CYP21A2. This will not be picked up by any other test apart from the specific test for CYP21A2. And if you're looking for an expanded, most of these single gene disorders, which are early onset and severe, you can go for a clinical exome or whole exome sequencing for the carrier analysis. So this couple came to us in a genetic clinic with recurrent IVF failures. And as Dr. Meenakshi also emphasized, the best single test for infertile couple is a karyotype. Wife karyotype was normal, and the husband karyotype showed a balanced translocation between 2 to 17. It is important because it can lead to infertility, it can lead to recurrent pregnancy losses, and it can lead to a child with developmental delay or malformation also. The options for them is to go for an IVF and pre-implantation genetic testing, or if the couple is not infertile and has presented with the recurrent pregnancy losses or child with developmental delay, conception and the invasive prenatal testing during pregnancy will be the ideal way. And coming on to the pre-test counseling in the carrier testing, of course, always we have to start with the family history, personal history, explain why are we doing that, what we are doing, and these outcomes are important. So there are 3 possible outcomes for the carrier testing. 1, it is normal or negative. It means both the partners are not being detected as a carrier in a common gene. So what we say that they are not at significantly higher risk for a significant disease in a future offspring, but they fall back to a background chances of 2 to 5%. If both partners are identified to be a carrier in common gene, or female partner is a carrier for X-linked recessive gene, then their future offspring is at risk, and the options given are IVF plus PGT or invasive testing in pregnancy, either by CVS at 12 to 13 weeks or by amniocentesis at 16 weeks. As Dr. Meenakshi also said, because genetic testing is not straight away, and many a times we get some uncertain findings which we do not know how to decipher. Those variants are called as variants of uncertain significance. Typically, laboratories are not keen to report those variants of uncertain significance in a reproductive carrier. But sometimes if the family history is significant, then a laboratory might have to report it. But let me tell you, as a clinician, no clinical decision has to be made based on variants of uncertain significance without a consultation with a genetics professional. And we have to give them limitations. We have to tell them that even if carrier testing has shown something, there is always a residual background risk. And we cannot know everything and we cannot tell them everything. And some uncertainties will always be there. What do laboratories have to do? And as I have told that only significant findings which are definitely associated with a disease, they are pathogenic or likely pathogenic variants, they are only reported. Typically, as of now, no lab in the world, the mild disorders, predisposition to cancer, adult onset multifactorial disorders like diabetes, hypertension, vitiligo. Carrier screening testings are not reporting those variants. Then coming on to post-test counseling, it is as equally important as the pre-test counseling. We have to explain them the report in a simple language they understand. If the negative, it means the couples have not been identified to have a significantly higher risk in the future generation. We have to give them the background risk and a routine follow-up in pregnancy, aneuploidy screening, ultrasound, NT scan, and whatnot. If that is positive, as I said, options of IVF plus PGT or prenatal diagnosis. And variant of uncertain significance, it's not a decisive factor for a decision. And we always write in our consultation notes, counseling notes, that all genetic tests come with limitation. A normal or a low risk screening test significantly lowers the risk of severe genetic disorders in the offspring, but there is always a residual possibility of a genetic disease. We also have to discuss in detail if the positive findings are there. We have to explain what is the genetic disease, what can happen to their future children. If they are having difficulty in conception, then IVF and pre-implantation genetic testing. If they are not having any problem in conception, but still they do not want to deal with the genetic testing during pregnancy and subsequent discontinuation, then also we have to discuss the option of IVF with PGT or IVF with donor gamete or donor embryo, because I see a lot of acceptance in couples nowadays. And if they are keen for a natural conception, then prenatal testing and the targeted testing is important. And these options, advantages, and limitations should be discussed, keeping their social religious beliefs in mind. A couple of examples. So previous 4 or 5 affected children, neonatal deaths, children not alive, no sample saved. If the sample was saved, ideally we would have liked to start with that child or sample first. But if that is not alive and there is a 3rd-degree consanguinity, that gives us even more confidence that this disease is genetic, mostly recessive in origin. And the couple were found to be a carrier for a gene which causes methylmalonic aciduria. Another scenario where the ultrasound showed some severe lethal skeletal dysplasia, fetal sample was not saved, and the couple was detected to be a carrier for a short rib thoracic dysplasia with or without polydactyly. Like this, we can have so many examples, and sometimes in consanguinity, being a carrier for 2 genetic disorders are not uncommon. And the genetic tests, the utility, which gives them this option to be identified as such. So I think I will stop here and I would be happy to answer if we have any questions. Thank you so much.
Thank you for the amazing talk, ma'am. It was really eye-opening that, what test we can order in, and certain tests like SMA, we don't even test in general practice. So we can offer those tests also to the patient. So thank you so much for such a good session. I will ask the audience if there's any question, please put it in the chat box. And ma'am is here with us. We have next panel with us. Just 1 minute. Thank you so much, ma'am, for the talk. So with that, I would like to invite the next presenter. So we have the next panel, and for that I would like to invite Dr. Seema Thakur ma'am. She is Director Medical Genetics at Fortis Hospital, Delhi. Madam is also visiting consultant at Rainbow Children Hospital, Delhi, and she has a genetic clinic in Dwarka, Delhi. Ma'am has multiple publications, and her main area of interest is prenatal diagnosis and genetic counseling, fetal and pediatric syndromic diagnosis, cancer genetics, and genetic disorder. And ma'am will be hosting the panel discussion on genetic testing in clinical practice. So, ma'am, with that, over to you.
The panelist, you will be introducing Dr. Bhavya?
Yeah, ma'am. I request Dr. Vibhu to introduce the panelist, please.
Yes,
I'll
yes.
change the slides.
Very warm welcome, ma'am. It's a pleasure. It would be a pleasure to hear you on this much coveted topic around. It would be my pleasure to introduce all our esteemed panelists for today's session. Our first panelist would be Dr. Vibha Jain. She is a consultant at Anuvanshiki, the genetic clinic at Ghaziabad. Her special interests are in maternal and fetal genetics and pregnancy losses and monogenic disorders. She's a doctorate in medical genetics from Sir Gangaram Hospital, and she's an obstetrician as such. Our second panelist for today's session is Dr. Vandana Chadda. She is a gynecologist, and she has various areas of interest are in fetal imaging, fetal interventions, fetal therapies, multiple pregnancies, as well as fetal genetics, with various publications. Our third panelist for today's panel discussion is Dr. Ranjana Mishra. She's also a gynecologist and a clinical geneticist. She's practicing at Yashoda Hospital and Research Center, Ghaziabad. She's a consultant geneticist there, and she has various publications to her credit. Our next panelist for today's panel discussion is Dr. Hemlata Vathwani. She is a unit head and senior consultant medical genetics, fetal medicine and molecular oncology and cancer genetics at Max Super Speciality Hospital, Delhi. We welcome you, ma'am. She's also the founder director of Apex Super Speciality Clinic, Delhi. Another last panelist for today's panel discussion is Dr. Mayank Nile. He's MD Pediatrics and DM Medical Genetics from STPGI Lucknow. He's assistant professor at Department of Medical Genetics, PGI CH Noida. And he has also been actively involved in management of various children with spinal muscular dystrophies and various other pediatric disorders. We welcome all our panelists today. I would request Dr. Seema Thakur to further take up the panel discussion. Thank you, ma'am.
Thank you, Dr. Bhavya and Dr. Vidhu. I'll share my slides.
Yes, ma'am.
Are my slides visible?
Yes, ma'am. Yeah.
So, good afternoon, everyone. So, as we know that the genetic testing has come up in a big way, and in a country like India, we really need this genetic and genomic testing. So, the cost has been, prohibitive in the initial days, but now the cost has gone down significantly. The pace at which the genetic testing has come up into the clinical practice, the knowledge of the obstetricians and the clinicians is lacking. So it's high time that we need to understand that the genetic testing, how to utilize them as a standard of care in the obstetrics or all other, I mean to say, in all other branches of medicine, so including the cancer genetics, the neurology, the nephrology. So and no one is spared. Every branches of the clinical medicine has to be well versed with the genetics and the genomic testing and how to integrate them. Today, we have selected this in the utility of the genomic testing in the area of the obstetrics. So my panelists, I have assigned different cases to each of them. So Dr. Vibha will be discussing about the RPL. Dr. Vanna Chadda, I have assigned a case with 22q deletion. Dr. Hemlata with the intellectual disability case, how to approach. Dr. Ranjana Mishra, how to approach a case and investigate a case with male infertility. And Dr. Mayank, who is a pediatrician. So a background of the primary amenorrhea. So the miscarriages can be sporadic, they can be recurrent, and sporadic are generally the fetal abnormality. It is the recurrent which is due to the maternal abnormalities. And incidence of both the sporadic ones increases with the maternal age, and recurrent abortion, the incidence is about the 1% of the women. And there are various risk epidemiological factors which are assigned, and the most commonly till now we have been knowing the advanced maternal age, number of previous miscarriages, but the latest guideline also suggests even the advanced paternal age is contributory to the recurrent pregnancy loss. Then black ethnic background, the consanguinity, that also increases risk to a bit. Then different addictions with the smoking, alcohol. So my question is to Dr. Vibha. So how do you define the RPL?
Thank you, ma'am. So, traditionally, we used to define the RPL as three or more miscarriages, but now, for all practical purposes, it has been said as per ASRM or ESHA that we should start RPL workup after two or more clinically recognized pregnancy losses. So, and in couple, the incidence is around 1 to 2%.
Yeah. So less than 20 weeks is defined as RPL, two or
20
more,
or
and
22.
more than 20 weeks is stillbirth. So how do you counsel? Like this is a very common scenario. So that's why I selected this as a first case for any practicing obstetrician. So she is faced with a case with the recurrent abortions, two or more abortions in the first trimester. So what to say in the first visit?
So, ma'am, such women are actually in distress. We have to counsel them first about the cause of the recurrent pregnancy loss. Because, as you said, there are a lot of causes which can be eliminated, like if there is hypothyroidism or hyperprolactinemia, that can be eliminated. Apart from that, we should tell them that the risk of miscarriage, as per a Lancet study, it increases the number of the pregnancy losses. So in any primary, it is 10%. Likewise, with one loss, it becomes 20, and then after three, it becomes 40. So the workup for pregnancy loss is very, very important. After two miscarriages, that is how the definition has been taken. Then we have to tell the mother that age of the mother is also important in the counseling of recurrent pregnancy loss, since the risk increases with maternal age.
So the etiological diagnosis is important. So just highlight the common causes of the recurrent miscarriages.
So it is most common. We all evaluate for this. That is antiphospholipid antibody syndrome, which is seen in 15 to 20% of the cases, and we can manage this disorder. We all know about it. Then anatomical defect of the uterus, like uterine some space occupying lesion or uterine diatality or bicarbonate uterus, they all constitute about 6 to 7%. Then endocrine factors in the mother, they are also important and they constitute around 15 to 20%. All those hypothyroidism or anti-TPO antibodies or hyperprolactinemia. Then genetic cost, which accounts for 5% of the cases. Today we are going to focus on this. And then 30 to 50% cost, they remain unanswered. So as we can see, all these causes are maternal based.
Yeah. So the RPL is multifactorial. Both genetic and non-genetic causes are, involved in the etiology. So we need to work up both the genetic and non-genetic. Today we are focusing towards the genetic causes. And recurrent causes are mainly maternal only. The sporadic one are 50% of the sporadic miscarriages are the fetal chromosomal abnormality. So this is the case of recurrent pregnancy loss due to the balanced translocation carrier. She is para 0 plus 5 and first abortion in 2014. And this was a biochemical pregnancy. Second was also a biochemical. In third one, she reached up to the 10 weeks with the cardiac activity, but the rest too has been UPT positive. Before she came to us, already she was investigated thoroughly. So, Dr. Veva, how do you investigate such couple?
So, madam, as you can see, the wife is a carrier of balanced translocation. So, that might be the cause of recurrent pregnancy loss in this case. As we can see, all other factors are normal. Only MTHFR gene polymorphism is present, and this factor is now not given much importance. So, we can see that the wife is a carrier of translocation. So, what happens when a patient is a carrier of translocation? Now, the translocation carriership is approximately 1 in 500 in general population. But when we see the data of the recurrent pregnancy loss cases, it is around 5%, which is very, very high. So when a couple is a carrier of translocation, they themselves are healthy because there is neither gain or loss of the genetic material, but they are liable to produce gametes which carry unbalanced chromosomal unbalanced genetic amount. It could be either monosomy or trisomy of a segment of the chromosome that we will see in subsequent cases. They are having recurrent pregnancy loss risk, or they may be risk of child with malformation. Both occur at a frequency of 30%. So, what are the options? We can go for pregnancies as we discussed. Level 2 ultrasound is a must at 18 to 20 weeks, because if abortion doesn't happen, then the baby is at risk of having some congenital malformation. Option as there could be donor sperm or donor oocyte donation, or we may go for PGT-SR. We will discuss all this in detail.
Yeah. So, can you explain this karyotype, Dr. Vibha?
Yes, ma'am. So, as you can see in this karyotype, you can see two arrows, one at the Q arm of the chromosome 1 and another arrow is at the Q arm of chromosome 3. So, actually, a part of the chromosome 3 is translocated to part of 1 and the 1 is translocated into 3. So but this translocation is balanced. As you can see, there is no gain or loss. But when the gametes are formed, they are 20, so the gametes will carry 23 chromosome out of 46. So there are chances of either monosomy or trisomy of a segment in the gametes.
Yeah. So when both normal would go, the child will be normal. When both the translocated one, the child will be normal. But when the opposite happens, one normal and one abnormal, then that would result in the malsegregation, resulting in either monosomy or trisomy, which will result in the unbalance. Can you detect this on the microarray? This balanced
No,
translocation
ma'am.
carrier?
Balanced translocation, ma'am, we cannot detect on microarray unbalanced. So that is the one of the indication for going for parental karyotype in cases of recurrent pregnancy loss, especially
Yeah.
if we found this type of unbalanced translocation in PFC.
Yeah, so we should only order the karyotype in the cases of RPL for the couple, because here the aim is to detect the balanced translocation carrier, whereas the microarray cannot detect the balance. They are good for the unbalanced karyotype only. So this you have already said that barrier balanced translocation are healthy people, but they have a risk of abortion of about 30 to 50%, and they have an option of natural conception. So where do I say that go for natural conception followed by amniocentesis? And where do I say that, it is best to go for the PGTSR? So I see that how is the fecundity or the fertility of the woman. If she is very good fertile, like in this particular case, then I would encourage her to go for the amniocentesis, because the success rate is very high, about 50 to 70%. So we'll tell them to go for the amniocentesis for the karyotyping or the microarray. And if the fertility is less, and on the top of it there is a abortion, recurrent abortion like this, then these are the candidates for the IVF, followed by the PGTSR after discussing with the IVF lab. So there are certain guidelines that there is always a dilemma that whether the PGTSR is beneficial in the balanced translocation carrier. This is the latest guideline by the RCOG, and they say that the time to pregnancy is similar in both the control group, who go with the PGT, who do not opt the PGTSR, and those versus those who opt the PGTSR. So the live birth rate, the miscarriage rate, and the pregnancy rate is similar in both the cases. So there is no added advantage of PGTSR in couple with the balanced translocation carrier. Similarly, for the idiopathic RPL, many women are suggested the PGTA, but the latest literature says that the live birth rate is similar, whether you go with the PGTA by the IVF, or whether you go for the natural, the without PGTA. So so overall at present, the couple should be informed of the risk and the significant cost of the undergoing the PGTSR and PGTA, as well as the lack of evidence regarding any improvement in the reproductive outcome. So we should avoid routinely informing them about the encouraging them for the PGTA or the PGTSR, because even this latest guideline also do not support. They suggest that the live birth rates are similar. So, Dr. Vibha, what are the tests would you want to do on the product of conception? Suppose there is a recurrent miscarriages.
So now, when there is recurrent miscarriages, definitely I will like to order chromosomal microarray, because this is the first tier investigation recommended by the Society of Fetal Medicine. Along with that, to check for the chromosome, we may order karyotype also, because if karyotype is abnormal, I can see it. It's visually we can see that if there is a karyotype, if there is a marker chromosome, we can see it in karyotype. If there are major anomalies that are easily visible in karyotype, so I'll prefer to order both. For chromosome, we can go for fish QFPCR also. One thing is important: whenever we send the sample for POC, we need to check for maternal cell contamination, and for maternal cell contamination checking, QFPCR needs to be done, because it cannot be checked by any other test.
So how the commonest question, because as we discussed, that the recurrent pregnancy loss or the sporadic miscarriage is very common in the life of an obstetrician. So very commonly I'm asked that how to transport the POC for the genetic testing. So it is the collection of the abortus material aseptically, and it can be transported at room temperature. If you have collected the special culture medium, either in that, or if that is not available, which is usual practical scenario, so you can open up a sterile normal saline and collect your fetal looking like tissues and send them at the room temperature to the testing lab. And there is a big advantage with the microarray these days, because the culture failure rate is very, very high. So we are not doing the karyotyping. We are routinely sending for the microarray along with the maternal cell contamination. And this can also detect the uniparental disomy. So for all practical purposes, all POC testing has been replaced at our center by the microarray testing along with the maternal cell contamination. So this is how, if we have to send the placenta, we have to take a a small piece of from near the cord, which assures that this is a fetal tissue. Still, we would prefer to do um, uh, the maternal cell contamination. This is the next case where again there is two miscarriages, and the third pregnancy was terminated in view of the NT more than 99 centile, and the karyotype was done, which suggested that there is an unbalanced karyotype involving the chromosome 7 and 10. And based upon this report, the parental CMA was done, which was normal. In the next pregnancy, the couple underwent the PGTA IVF because of this, and the recurrent miscarriages and the unbalanced karyotype. And the results of the PGT was shown, like there is the 7 to 10 translocation. There was some unbalanced. So this was a chaotic report, and now the couple was referred for the genetic consultation. So now Dr. Vibha, so Dr. Vibha, please explain this karyotype. So this was your case only.
Yes, ma'am. So, ma'am, in this case, as you can see, the mother is a carrier of translocation between 7q21.1 and 10q11.3, while father's karyotype is normal. So, that is the cause of all those unbalanced genetic material seen in the fetus. So, what happened in this case? Instead of going for karyotype, after two pregnancy loss and in the while doing workup for the RPL, the doctor sent only the sent a sample for parental microarray. So again, this case emphasize that parental microarray doesn't pick up the balance translocation. So it is not the testing of choice in a case of RPL. We should always go for karyotype of the parents and microarray in the fetus.
Yes.
So this could not be picked up in initial investigations.
Yeah, because here you want to check the balance translocation carrier. So the balance will not be checked by the microarray. So that's why we should always, or in a couple, we should order the karyotype. In the product of conception, we should order the CMA is the first year test in this. So this was the karyotype of the lady. So would you like to explain this figure as well, Dr. Vibha?
Yes, sir. So this slide explain how there will be segregation of the balanced translocation carrier chromosome. As ma'am has said, if both the chromosome, if the fetus take both the normal chromosome from parent, then it will be normal obviously. But and if it take both abnormal also, then it will be normal. Then because then fetus will also be a carrier of balanced translocation as the parent is. So roughly we can say that 50% embryos are normal. But if there is one normal chromosome and one derivative chromosome is taken, then all those cases and this lead to either loss or gain. So the 25% loss and 25% gain will be there. So we can
Yeah.
say roughly that 50% will be abnormal and
Yeah.
50% will be normal.
So, which will result in either abortion or a child with the physical
And
abnormality. So we should always offer the amniocentesis even if the pregnancy continues beyond the period of abortion in a particular family, because there may be smaller deletion or duplication which can result in the mental or physical handicap without being having abortion. So it is always amniocentesis should be offered. Yeah. So some take home messages, Dr. Vibha, from your case.
So the take home is so unexplained RPL cases they remain unanswered. They usually remain unanswered, but genetic testing can give answer in few of these cases. Now, microarray is the first line investigation of POCs since chromosomal abnormalities are identified in 50% cases of pregnancy loss, which is high. Whole exome sequencing can be added, especially if there is some soft marker or if there is congenital malformation that is indicative of some syndromic etiology. Karyotype, it helps in identifying if parents are balanced translocation carrier that we discussed. CMA in RPL couple may not be beneficial.
Yeah. So thank you, Dr. Vibha. Now we move on to the next case. This is a case of DJOY syndrome, 22q deletion, a very common microdeletion. Rather, this is the commonest genetic syndrome after Down syndrome. And this was a fetus which was referred to me with one of my colleague, because on the ultrasound she was not sure whether the cardiac abnormality is the DORV, the double outlet right ventricle, or whether this was a pallotetralogy. So the moment I saw the fetus, there was subtle dysmorphism, but as you know that this is not very clear in the cases of fetuses, one cannot comment. But yes, there was a bulbous nose, long philtrum, thin lips. When I opened the fetus, immediately I noticed that there is an absent thymus, and with a cardiac abnormality we found out that yes, this is a case of 22q disorder. So what are the my question is to Dr. Vanna. So what are the cardiac abnormalities? You do lots of scans. So what are the common cardiac abnormalities you would expect in a case with the DJOY syndrome?
Yeah, so whenever we see a cardiac abnormality, unlike other abnormalities, our approach is always to order, like even before the microarray had started, even before we would be ordering a karyotype with a 22q microdeletion fish, because even then we realized that there is a higher association. Am I audible?
Yes, yes, very much.
Okay, so even then we had realized in the pre-microarray era that there is an association between 22q microdeletion and cardiac abnormality. So the cardiac abnormalities in general we would order for almost everything, but the typical ones would be the arch abnormalities. So an aortic arch abnormality or an interrupted aortic arch or a truncus arteriosus, they listed here, but tetralogy of Fallow is something which typically we would always like to rule out the 22q microdeletion. But more or less, other than for the isomerisms, I guess the list covers a lot of these common anomalies that we see.
Yeah, so it is mainly the the
Yeah,
outflow tract and the aortic arch abnormalities,
yeah.
the 22q. So what test would you offer in current times in this CMA era?
Yeah, so once we've got a micro array in hand, we know that the micro array would pick up all of the deletions associated, even if it's a large deletion or a smaller deletion and atypical deletion. So micro array would be the test of choice in the current era to rule out a 22q micro deletion
Yeah,
associated with the cardiac anomaly or even
yeah.
otherwise.
So copy number state 1, this is a loss on the
Yeah,
chromosome number
you see
22,
that, and the
and this
size flower
and
like
size is 2.7
almost
MB and a
and
huge 85, so reported as pathogenic.
if you go back to the previous report, this is what a typical deletion
Yes,
would look like and cover about 85% of the population. So you can see that the number is almost 3 MB, and that is what the classical deletion would look like.
22q deletion, yes.
Yeah, and that would be the
Yeah.
majority of those.
But
Yeah.
here is another case where the deletion is
So you
just
can see
782 and
compare,
less
yeah.
than 1,
You can
less
compare
than
there
1
it
M.
was 3000, and the number here for those who are not well versed with genetics, you can see
Yeah,
the number here is 782. So there it was 3000 kilo
yeah. So
or
this is like,
CP, and here it's
2797,
yeah,
2797. This is in hundreds only,
yeah, it's less than
782,
1000.
and you can see the KBP,
So
right?
if you are having an atypical deletion which is smaller and not covering a large area, and if you do a very targeted fish test, if the
This
non-genetic
might be
population,
missed. Yeah.
you might miss
And-
it. So the
Yeah.
larger the area, it will be covered by any small fish also, but a smaller deletion may not be picked up. So
Yeah.
this
And
is
the
an
color also
atypical.
says that this is a deletion, the red color.
Yeah,
The
and the more atypical the deletion, Dr. Seema, is it like more nested it is, it's more likely to be inherited. Is that
Yes,
also
yes,
true
yeah.
to some extent?
So, so like this fetus has got 22q deletion. Suppose this was during pregnancy. So what do you tell the parents?
Yeah, so if you have that the smaller deletion, and the reason you did it was soft markers and all that, and then you found that 700 deletion. So we
Yeah,
have to tell the parents that this is a condition. It is autosomal dominant, but it is also it can be de novo. It's not necessary that it has come from the parents only. Only about 10% cases would come from a parent. The rest of them could have happened by chance, or there could be a small mosaicism element there, but mostly it has come de novo. So if the parents continue this pregnancy, we'll obviously have to enlist the features of D George to them and tell them that some of the features may not be obvious in every uh,
yeah, yeah.
individual, and it's a very atypical like that presentation may be variable based on the particular case. So one case may have more severe features, the other case may have less severe features, and because of this variable penetrance and
So
presentation,
difficult.
difficult to counsel. So the
Yeah,
learning
difficult to
disabilities and
prognosticate. Like in the second case, we did have problem. Like, because the size is very less, the fetus
less,
doesn't have any problem.
yeah,
So, we
counseling can be
wanted to,
difficult.
yeah, it was tricky. It
Yeah,
was,
you can go back and check the parents. If one of the parents is carrying a similar mutation, they may be more reassured, they may have more inclination to continue the pregnancy. But it can get very tricky, especially if the parents read a lot and they get very put up that
yes.
what can happen.
And
That's
also, we
uncertainty.
cannot give them for sure that the child will
Uncertainty. Yeah,
behave like parents only. Most likely they will, but there may be uncertainty. So these are tricky situations.
yeah.
So are all 22q deletions same? I think you have answered.
We already understood that, and this is the gene that you're showing here. So we can see the gene can be has been divided into these A, B, C, D, E, F, G, H regions. And our the first case that we had shown the 3000 kb. So that's the 3 MB standard deletion denoted in the gray. Dr. Seema, if you can mark it for us. So that is the common one, and you can see this is the classical one. but you may have smaller ones which are not that large. So you may have a deletion which is just about 1,000 kilo
It
base
could be
pairs or
a
one M,
nested
yeah,
one
and
sitting
the
between
nested
them.
ones which are much smaller, yeah.
Yeah.
So
And
this.
we also had one case of distal deletion, and where the ultrasound finding in utero was nothing. It was just an ecogenic focus. And when the child was born, this was one of the twin conceptions. The other twin was doing very good, and the second twin was, failure to thrive, short stature, and developmental delay. And then the karyotyping was sent, assuming that this is a T21 only because of the ecogenic focus. But this turned out to be a distal deletion, which can have dysmorphic features and the developmental delay. So the majority of these are the classical 3MB, and some of them 5%, 10% can be the B to D or A to C deletion. So the test of the choice is always,
Microarray which
yeah, because
will
this
pick
is
up all of the
100%.
cases. So here we would like to point out that even in the parent, if you are trying to check for the same deletion, you will probably do microarray only, Dr. Seema.
Yes, yes. You will
Yeah,
not
that's
change
the
to a
point.
deeper test of fish, that because this may miss, and then you will wrongly label them as
So
that they are not
if
a carrier.
one of the parents, say for example, the second case has been terminated, and they come to us in the post termination, we can offer microarray to the parents to see if one of them is carrying a similar
Yes. Yeah.
mutation,
Same
and
micro
they can
deletion.
decide whether there is a
Yeah.
recurrence risk will be 50%. Then that
Yes.
that
Yes.
counseling is important then in
And
the.
there are chances, because this is a smaller one. So how do you counsel for the recurrence risk in these two cases? How do you counsel? So we have already discussed that it is 90% de novo, like Down syndrome, and 80% is and 10% is inherited. And germline mosaicism has been reported in this. So if it is inherited, then the risk of recurrence is 50%, like any autosomal dominant disorder. But if it is a de novo, the risk to the next child is slightly greater than that of the general population, because of the possibility of the germline mosaicism. And I would offer amniocentesis. Do you agree, Vandana, that for 22q deletion, even if it is a de novo, I would like I'm offering for each Down syndrome also.
So
So
it
there
is
is,
individual. I distinctly remember one case where we had diagnosed post cardiac defect, uh, 22
yeah.
micro deletion. Then the lady came to me in the next pregnancy also for the counseling also, an initial. I kept asking them to do the 22q for themselves. They said, if you mention 22q again, we will not come to you even for ultrasound. So
Yeah.
I think you have to explain the things to the couple, and they have
Yes,
to
yes.
make those
Yeah, so
choices.
we have to offer non-directively. It's
Yeah.
the couple's call.
So
And the phenotype in a SIB who inherits the deletion, that cannot be predicted, because 22q is associated with the significant intrafamilial
yeah.
clinical variability, and that creates the dilemma in the genetic counseling. So now we move on to the next case with Dr. Hemlata. And this is a case with the family history of intellectual disability. This lady had come to us during 6 weeks of the pregnancy, and she was referred to us because the husband's sister had intellectual disability. So at this visit, neither the patient was there, and only the husband has come. He just wanted to know. So we told them that we need to see the index case. And when the girl came, she was 33 years old girl, and with born to a non-consanguineous parents, and she had seizures, intellectual disability, microcephaly, spasticity, and on anti-epileptic drugs. But MRI brain was normal, and one odd report was, so till now there was not enough workup, and she was able to cope up with the limited physical activity, limited IQ. She was able to stay inside the house with the help of the support of the family members. So we so, Dr. Hemlata, how do you investigate such cases? And the causes, the utility. So how do you select your genetic tests in such cases?
Yes, so thank you, Dr. Seema, for this case. So the thing is that whenever a patient comes to you, suppose say a pregnant lady comes to you for the first time, and I always tell the obstetricians to please screen, take the basic history, three generation basic, the history of the family, like are there any members who are affected with intellectual disability or developmental delays or seizures and stuff like that. Like in this case, there was this husband whose sister was affected with intellectual disability, so that's how you start, and you start building up from there. there. Okay. And then, of course, I mean, one of the treatable things, that thyroid, so you mentioned it also here, right? So thyroid is another thing I always ask, because thyroid is easily the most treatable, very easily treatable cause of intellectual disability in, everywhere around. So the thing is that, whenever a case comes to you, take a detailed family history, number one thing. And second thing is that, I always say intellectual disability is like a symptom, like fever. Okay, so like you investigate a case of fever, likewise you start investigating a case of intellectual disability. Take a detailed genetic family history, then start asking very specific questions. Specific questions, as in, suppose a case with intellectual disability comes and you ask them that were there any developmental delays? If the developmental delay was there, then what kind of developmental delay was there? Was it predominantly motor delay or a speech delay, or was it a global developmental delay? How was the growth centiles? How were the curves there? Okay, so a lot of things, any history of any altered bowel or bladder habits, or things like constipation, things like, regurgitation and vomiting, repeated hospitalizations. So you have to be very specific, it's like targeted history after that. And then followed by that, you start narrowing down, and then you come down to the examination. Okay. So then in the examination, of course, you start from head to toe, always undress the person and see from head to toe. And sometimes you have to be very sensitive. Like in this case, this girl is actually 33-year-old female. So, so one has to be very sensitive about the part that, you don't kind of undress her straight away. You have to be very sensitive here. And, you have to have, like for males especially, you need to have a female attendant with you while you're examining the girl. So there, again, go in from head to toe examination. Do not miss any findings of dysmorphism or any other stigmata out there, any birthmarks, any tone abnormalities like hypertonia. So the whole clinical evaluation starts from a very basic history, 3-generation basic history, followed by specific questions for the clinical questions actually, and then followed by the exact examination findings. So likewise, you start narrowing down, and I always say that there's no one single test which is going to kind of, fit in to diagnose a case of intellectual disability. So the tests, the genetic tests that you do for any case who comes to you with intellectual disability are targeted according to the history and the examination findings. So that's what we do. So yes, so that's what has been mentioned here. So what you do is then accordingly, then you can always order the supportive investigations, like, you can always order them MRI or a fundus examination or hearing examination, and then metabolic screening, depending upon what you get, supposed to. So TMS and GCMS. And then finally, I mean, I would always say that, finally, when everything fits in together, then you start thinking that, okay, fine. Broadly, is this a case of chromosomal abnormality? Is this a case of single gene abnormality, or is it a case of, say, the UPD and the imprinting disorder? So that's how you kind of, classify it in your mind, and that's how you go about it. And of course, I mean, I always say rule of thumb is that, always keep the commonest disorders first. So like, if there was a male who had come to me with the intellectual disability, and suppose if on the examination findings, I had found that the child has certain dysmorphism, which is suggestive of fragile X. Okay. So then you go in straight away for the test for fragile X. I mean, there's no point, getting so many associated investigations done. So it's a very meticulous examination that I think, helps us in kind of getting the genetic test done. So yes, so MRI, so the diagnostic yield for the tests in global developmental delay, which with intellectual disability would be like MRI yields around 50 to 60% of our results, karyotyping another 3 to 15%, microarray another 15 to 20%. Fragile X screen, as I said, that after Down syndrome, Fragile X is the most common cause of intellectual disability in males. So then that is around 2%. Then NGS, which is predominantly, I think everyone thinks, that NGS aa gaya, whole exome ho gaya, and that's it. It is going to give you all the answers. But see, I mean, the yield there is only 25 to 30%. And of course, metabolic testing is of great value if you are suspecting a metabolic disorder in a child or even an adult. So that is around 1 to 3%. The yield is around 1 to 3%.
Yeah, so you have to do the thorough, history, including the antenatal, the postnatal, the milestones, then you have to exclude genetic, non-genetic, all. So the diagnostic yield.
Exactly.
So we
Exactly.
did,
So in this case, yeah.
yeah. So because this was, she has come for a genetic consultation. So we directly did this time we did all the chromosome, the microarray testing. We also did, because the time was a constraint. So we did the trio whole exome testing for the, along with the parents, and also this brother whose wife was expecting, and also because suppose there was some carrier, so his wife was, so extensive testing for the almost whole family member. And we were taken aback when the microarray came normal. So all the whole exome sequencing was actually they're not cost effective for us. So thankfully the whole exome sequencing of the parents had revealed that this girl, she has a 3.3 MB loss on the chromosome 9p. So this was consistent with the 9p microdeletion syndrome. And thankfully the whole exome sequencing of the parents has showed, because as you know, the copy number variants can be picked up in that as well, that this was a de novo in case. And the brothers carried the microarray was ordered later on, and his was also normal. So finally we concluded that this was a isolated sporadic case and unlikely to be repeated in the brother's pregnancy. And so so majority of the intellectual disability, many of them would be sporadic. And this needs a thorough workup, ideally in the preconception and in the early pregnancy. So it's just an approach. If you can if you can summarize,
Yes.
Dr. Hemlata. So just
Yes,
for the
so
genetic
as I
testing.
said that, yeah, so then for detailed history, after detailed history and clinical examination and, the relevant findings like dysmorphism and all, and irrelevant tests, very basic relevant tests like MRI and hearing and fundus. So after that, you broadly classify whether it is, does it fit into any chromosomal single gene or a metabolic disorder, or is it, a non-specific intellectual disability that you're dealing with. Sometimes the symptoms are very vague, and it becomes very difficult to kind of fit them into one picture. So then in
Yeah,
that case,
majority of the times rather.
majority of the times rather, exactly. So then that is where, I think the first approach would be, go ahead with chromosomal microarray. As per the guidelines, that's how we'd go about it. You go ahead with microarray analysis. And along with that, of course, MRI brain is a very big, it has a big advantage there sometimes, that, at least you rule out the structural abnormalities first. And then, of course, then if you feel that, yes, there is some element of autism, and maybe, there are some criteria like, suppose there's a female there and, you're suspecting Rett syndrome, then maybe going for that study. And I told about, that, a male with intellectual disability, of course, rule out the commonest causes like Fragile X first. And then, of course, if nothing works, and if everything turns out to be normal, then the last resort for me would be NGS, unless I find a specific syndrome during my clinical examination. Then, of course, you go straight away for an
Or there
NGS-based
is a
test.
consanguinity, or there
Yeah.
is a family
Or if there is a
history
consanguinity.
suggestive of
Yes,
single gene
yes,
disorders, then we
yes,
would
yes.
first go. Otherwise, as per the guidelines in 2013 by the American College of Medical Genetics, they suggest the microarray as the first year test in cases with the postnatal developmental delay, autism, or the physical abnormalities.
So I would also like to add another thing here, that another situation that all of us, all the obstetricians come across is probably cerebral palsy, So this is another very common history that we come across, that the child had CP, and that is attributed to be the cause of intellectual disability in the affected child or in the family. So, I always say one thing, that think beyond CP. Why did even CP happen? So you have to kind of know CP is again a symptom like fever. Right. So, unless you kind of find out the cause, that why didn't the child even cry at birth, which is supposed to be a normal physiology, that the child has to cry after birth. The child is not crying, and that is leading to CP. Then what was the reason for the child not crying? So start digging there also. Just go a
Yeah.
little deeper and dig
Yeah,
there
so even
also,
the
what
simple
happened there.
CP once turned out to
Yes.
us for the alpha thalassemia with mental retardation, ATRH. The first
Exactly.
child came
Yes.
and there was a white matter hyperintensities, and we passed off, oh, this is all due to the birth hypoxia, and next pregnancy you are not going to have these problems. And but the next pregnancy she again came to us with the second male child who had the similar problem, and this time we detailed, and that was not the time of NGS and all, but we with the the thalassemia HPLC, we could see the hemoglobin H band and the brilliant crescile staining, and that showed that this is a case of alpha thalassemia. So good that you pointed out rightly that majority are being labeled as cerebral palsy and they don't even see the geneticist. But some of them, I am not saying that all of them are because of the genetic disorders only, but maybe a good chunk of them can be a the genetic disorder. So whenever there is a family history of the child with the, so how to introduce this into your practice. So in the busy practice, whenever in the obstetrics is a very busy OPD, but there are two questions which I would say that everybody should ask: whether there is any family history of intellectual disability, and second is the consanguinity. Because unless you ask these direct, because the role of prevention is by the leading questions only, they will not come up. If sometimes I ask, why didn't you tell them that, and they would say, because that person has passed away, I did feel this important to inform my obstetrician.
Exactly.
They refer to me
Yes.
at 26 weeks of the pregnancy, and I say fragile X in the family, and they had said कि why didn't you tell, वो तो death हो गया था तो हम क्यों बताते, so the meaning that they gave us a message that we have to do the leading questions, and these two leading questions will work many of us where in a busy OPD, that whether there is a family history or whether there is a consanguinity, and so that we can pick up genetic disorders, because genetic testing has come at your doorstep and we have to utilize them, because, and it is very very cost effective, unlike other countries. When I go to other countries and they are not using that much the genetic testing, because they're the government role, the insurance, here the patient has to pay from their own pocket, and they're very very cost effective. So we are privileged to do all these testing in our country, so that so it's high time that
And
we introduce them as a standard of care. So
yes, and there is another thing, there is another pointer, just very little message, that please ask for the history of alcohol consumption and smoking also. The times
yeah.
have changed, trust me,
Yes.
and you do come
Yes.
across that history very
Yeah.
often. I've had two cases in last year, where
Yeah.
we did diagnose, we confirmed fetal alcohol syndrome. So,
Yeah.
it's really not that uncommon these days.
Yeah. They
So
don't
please
come up.
ask
You
for
have
the
to
history
ask.
of alcohol.
Yeah.
Yeah, so these
And
are not genetic causes, but then yes,
yeah,
they
the
are very
society is
much a
changing.
cause
So are
of
we. Yeah.
intellectual disability. Yeah,
One
so
has
that's
to
the other
ask
thing.
any teratogen,
Yes,
including the alcohol,
including the alcohol. Yes, right. Thank you. Thank you very
Thank
much.
you, Dr. Hemlata. With this, we move on to our next case of the infertility. Mainly, we are going to discuss about the male infertility, because the genetics plays more role here in the cases of the male infertility. So, Dr. Ranjana is with us. So, but how do you define, Dr. Ranjana, the infertility, and how commonly you are seeing this?
Thank you, ma'am, for this question. As per the literature definition, infertility is said, it is defined as inability to conceive after 12 months of unprotected sexual intercourse. And it has been found to affect about 15% of couples worldwide. In fact, it is said that as per WHO data, it has been found that one of six.
1 out of 6. Okay. So 1 out of 5 is 20%. So 1 out of 6 would be something around 15 to 17%. Yeah. We can't hear you, Dr. Ranjana. Yeah. So I think we have lost her connection.
Hello.
Yeah. Yeah. Now we can hear you.
Okay.
Yeah.
Yeah. So it has been seen that in female factors they contribute around 40%, male factors contribute around 40% again, and both females and males, they together contribute to the rest 20%. In fact, there is a small percentage which is idiopathic, where we don't find any underlying male or female cause also.
Yeah. So how do you, what are the tests to detect the male infertility?
It is very easy to detect male infertility, but just by doing a simple semen analysis and to test the gonadotropins, that is the FSH and LH levels, and serum testosterone. In a semen analysis, one should attempt to check for the serum fructose level, the semen fructose level also, which helps in differentiating between a obstructive and a non-obstructive cause.
Yeah, so this is the WHO criteria for the fifth centile, that the volume should be at least 1.5 ml, concentration 15 million, total sperm number 39 million spermatozoa per ejaculate, at least 4% should be normal, 58% should be live, and there should be a progressive motility of about 32%. So these are the minimum criteria as proposed by the WHO guidelines. So coming on to the male infertility etiology, Dr. Ranjana. Yeah, we can't hear you, Dr. Ranjana. Yeah. So as we can see here, that the male infertility, there is both the genetic and the non-genetic causes, and the genetic causes, they account for about 15% of the cases. Non-genetic would include even the physical trauma, infection, obesity, and the excessive alcohol, drugs, endocrine disorders, even the malignancy and undescended testes. So these are all non-genetic, and we will be discussing about the genetic causes, which account for about the 15% cases of the male infertility. So the genetic causes, the best is to distinguish them between the two basic types, the obstructive and the non-obstructive. And this is possible by the simple, the semen analysis, which shows that if there is an absence of fructose, then we are dealing with the obstructive azoospermia or oligozoospermia. But if the sperm parameter shows normal fructose, then we are dealing with the non-obstructive azoospermia. And non-obstructive includes both the testicular and the CNS, like the pre-testicular. So the pre-testicular, the causes commonly are the Kallmann syndrome or the pituitary disorders. And in the testicular, it is all the chromosomes like Klinefelter syndrome, XX male, XY gonadal dysgenesis, and the Y microdeletion. So the Klinefelter syndrome and the Y microdeletion are the most common causes of the male infertility in our clinical practice, and we'll be discussing those two cases. Then the obstructive causes, this could be due to the cystic fibrosis. Unlike the literature, we are seeing lots of cases of cystic fibrosis in our country too. Then there could be a congenital absence of the vas deferens without the cystic fibrosis. There could be congenital epididymal obstruction. So these are the cases of the obstructive azoospermia. Dr. Ranjana, are you back? So, Dr. Ranjana? I think we have lost her connections. So the non-obstructive, so hypothalamic, that is the central causes, the pituitary disorders, and testicular, that is the Klinefelter, XY gonadal dysgenesis, mixed gonadal dysgenesis, Y microdeletion, androgen insensitivity syndrome, 5-alpha reductase deficiency. And the common causes are Klinefelter syndrome in our practice, Robertsonian translocation carrier. Many of the translocation 13, 14, they will have the low sperm counts or the oligozoospermia. Then the Kallmann syndrome, androgen insensitivity syndrome. So the Klinefelter accounts for about 5 to 15%, 5 to 10% of the cases of the male infertility, and the Y microdeletion accounts for about 10 to 15% cases of the genetic causes of the male infertility. So this is a case who had come to me in view of the Y microdeletion testing. And when I looked at the FSH and LH level, this patient had azoospermia, and the FSH and LH levels were high. So this was indicative of the gonadal failure, where there will be testicular failure. So we suspected clinically as Klinefelter syndrome, and we can see here, this is a case of the XXY. So what should we tell after the diagnosis of Klinefelter syndrome in a male with the oligo or azoospermia? So this is a common chromosomal abnormality, and this is the commonest chromosomal abnormality in men with the non-obstructive azoospermia, and they will have raised FSH-LH, reduced testosterone, reduced testicular volume, and almost total atrophy of the seminiferous tubules. But it's not all that negative. We also counsel them that 50% of the cases of the Klinefelter, the sperm can be found upon the testicular sperm extraction, and this patient was then referred for the TC procedure. And now, Dr. Ranjana, are you back? Okay, I think I'll continue with this. So this is another case with the male infertility, which was later on diagnosed with the Y microdeletion. This they had come to us during the second pregnancy, when this was a triplet pregnancy, but there were no fetal pole in either of them, and of course no cardiac activity. The first pregnancy, there was a cardiac activity present, but there was a spontaneous abortion, and the cardiac at the 7 weeks, and karyotype or fish on the product of conception was normal. This particular gentleman, he had azoospermia, and FSH level was almost normal. Testosterone level was also normal. Karyotype was normal, and fish on the semen was also normal. But he was positive for the deletion in the ZFC region of the Y chromosome, and these were the markers which expand the ZFC region. And so when do we offer the Y microdeletion? Whenever the sperm count is less than 5 million, or the European guideline would suggest even the less than 10 million, so the Y microdeletion should be offered. So routinely we are doing the karyotype. If the karyotype is normal, then we are doing the Y microdeletion. And in the Y microdeletion, these are the three reasons: SZF-A, SZF-B, and SZF-C. So if there is a deletion involving the SZF-A, then there will, there will be no spermatogenesis. So these only the donor is advised for them. Same is case for the SZF-B, but SZF-C, 70% of them can have children. So the Y microdeletion, if after the diagnosis of this, they will refer to us. So we tell them that this is the best known genetic causes of the male infertility, and found in 10 to 15% of the men with the non-obstructive agiospermia. Microdeletions mostly occur on the long arm, and deletion in the region are specifically related to the failure of the spermatogenesis. Three reasons: A, B, and C. And so 60% of the male have they do not result in the retrievable sperm, and these are the HZF-A, HZF-B, or HZF-B plus C. But one with the HZF-C, 70 to 80% will have sperm, so they can father children. But we should also counsel that affected father, they will transmit to the all, and leading to the compromised fertility potential in the next generation as well, in case this turns out to be the male child. So how to approach a case with agiospermia? So first we have to.
Has joined, ma'am. Dr. Ranjana ma'am has joined, ma'am.
Yeah, so Ranjana, you have rightly joined so just tell us about the approach with for the agiospermia or the oligospermia in the clinical practice, because you deal with lots of infertility IVF clinics.
Yes, ma'am. Thank you. Actually, I'm extremely sorry. I somehow lost the connection. So whenever we have to work up a case of azoospermia, we should keep the hypothalamic pituitary testicular axis in mind. And first of all, rule out the non-genetic causes by taking a detailed history and doing a good physical examination. I'm sure in the previous slides, you must have enumerated the non-genetic causes, like any history of infection, like mumps, any history of drug abuse, substance abuse. So just rule out any surgeries, retroperitoneal lymph node dissection, gonadotoxic chemotherapy. All these things you have to rule out. And then it's a good idea to divide the causes into obstructive and non-obstructive group. The obstructive ones would include all the anatomical structures beyond the testes, which will the post-testicular causes mainly. Under this group, we have cystic fibrosis, congenital absence of vas deferens, congenital epididymal obstruction. The non-obstructive group, it can be divided into pre-testicular and testicular causes. The pre-testicular causes would include the hypothalamic disorders like Kallmann syndrome, the pituitary disorders like isolated gonadotropin deficiency, either the FSH or LH deficiency. Under the testicular subgroup, the most common ones are the chromosomal disorders. In this also, the Klinefelter syndrome would be the commonest one. As a group, the chromosomal causes, they count to 5% of the total etiology. Then in this chromosomal group, we also have, apart from the Klinefelter syndrome, we also have XX male, where there is actually SRY. It's a chromosomal, the chromosomal sex is XX, but phenotypically it's a male because of SRY translocation. Then there can be XY gonadal dysgenesis or mixed gonadal dysgenesis. Then we can have autosomal translocations. Like in one of the RPL cases, it had been such a case scenario had been alluded to. Apart from recurrent pregnancy loss, autosomal translocations can also cause infertility, both in male as well as in female. Then Y microdeletion, as ma'am had already talked about in detail. Then we have single gene disorders like androgen insensitivity syndrome, which can be partial or complete. And we have, there is another entity called 5-alpha reductase deficiency. So this is how we can work up for the genetic causes of male infertility.
Yeah. So thank you, Ranjana. So so we would like to hear some take-home points from you for the infertility specialist particularly.
Yes, ma'am. So the main take-home point I would like to say is that a good phenotyping is the key to all your workup and the best yield of your genetic testing. all the professional bodies, most of them, they recommend that men with oligospermia, that is a semen count less, sperm count less than 5 million sperm per ml, or azoospermia, they should receive a genetic testing either by doing a karyotype or by microdeletion, or even for CFTR in obstructive etiology. As I've said, a history, good detailed physical examination, they go a long way in refining your genetic test. And it's always a good idea to categorize your etiology into of male infertility in an obstructive or a non-obstructive cause. And the genetic testing which we commonly use to work up a case of male infertility is the karyotype by microdeletion and testing for cystic fibrosis. And these tests not
NGS
only
maybe
establish
when these are normal,
for
so the
cystic
next
fibrosis
level can be NGS. Yeah.
or the single gene disorder, especially in syndromic cases,
Yes.
like Coleman, and there are many other syndromic like Bardet-Biedl and all those. So where we have ciliopathies, where they can be an apart from the systemic disease, there is involvement of
The ciliary dyskinesia, there will be angiospermia. So all these, so by the NGS based analysis, the common testing is karyotype Y microdeletion, CFTR in cases of the obstructive. But if these are normal, then of course the NGS in the current time we must offer, because there are other genetic syndromes like primary ciliary dyskinesia, Bardet-Biedl, as you discussed. They all can have, the male infertility, and they can.
Right. And they not only help in establishing the diagnosis, they have implications in transmission of
the recurrence risk.
the
Yes,
future
very right.
generation, and for
Very
the
rightly said.
overall management of the patient and the family
And the
and
family
the
as well.
screening.
Yeah, they will get the answer, so that they can handle these situations which are in a better way once they are aware of all these situations. So thank you, Dr. Ranjana, for your inputs. Thank you.
Thank you,
So
ma'am.
now we move on to the last case. I'm happy that we are going within time almost. So this is a case with a 18-year-old female, because she didn't achieve her menarche. So she was referred to us. Her breast was normal, but she had no axillary hair, no pubic hair. She was good height, 162 centimeters, 5 feet 5 inches. So a good tall girl with feminine looking only. And there was no inguinal hernia, no clitoromegaly, and she was already carrying her ultrasound, which suggested that there is no uterus in her, and her LH was high, 45 international unit, but FSH was to the borderline. So my questions will be to Dr. Mayank. So
Yes,
Dr.
ma'am.
Mayank, are you there? So
Yes, ma'am, I'm there, ma'am. Hope
what
I'm audible.
investigation now you will offer to her?
Yeah, ma'am. As already written there, we'll offer karyotype. If we can come back to the case scenario, ma'am, the previous slide.
Yeah.
Yes, ma'am. As we can see, this girl is having primary amenorrhea. Breast development is there. And the most important thing to see here is the ultrasound, which is showing absent uterus. So if absent uterus is there, we should offer a karyotype to know the genetic sex of the child. And
Yes.
as we can see, the karyotype shows 46XY.
So the likely diagnosis is
Yes, ma'am.
XY
female without
without
uterus, and probably she is having androgen insensitivity syndrome.
Yeah. So there are two basic indications for karyotyping in primary amenorrhea. One is the hypergonadotrophic hypogonadism, like in Turner syndrome or gonadal dysgenesis. Or the second one is the absent uterus. So by the absent uterus, so here the differential diagnosis. Recently, we came across a girl who was similar looking like this, a tall girl with a good feminization. And she was carrying a MRI report which suggested that she is a case of the Mayer-Rokitansky-Kusser-Hasser syndrome. But here, that we cannot label her MRKH unless we have her karyotype, because if the karyotype shows XX, then only she is a MRKH. So because the ultrasound is a commonly available modality, the FSH and LH was not done for her. So with the absent uterus, there are two, the main differential. One is the MRKH, which is the commonest cause of the primary amenorrhea, and the second one is the XY female without uterus, and of course the XY female with uterus, because they can conceive. So this is the
Yes,
So
ma'am. And that will also help in the planning of the hormone replacement therapy. Like for
yes.
MRK 46 axis, we are not going to give the HRT.
Yeah, we are not going. Yes, very rightly said. Very rightly pointed out. So, so next questions are towards you only, Dr. Mayank. So regarding, just tell us about the, the review for the premature ovarian
Yeah.
insufficiency or failure. So
Yes,
how do
ma'am.
you define and the clinically and all?
Yes, ma'am. So basically, premature ovarian efficiency, there are two criteria which needs to be seen. One is clinical criteria, and other is the biochemical. So any cessation of the menstruation, like in a reproductive age group women or a girl child of primary or secondary amenorrhea lasting for more than 4 months with FSH elevation of more than 25 units on two occasions more than 4 weeks apart, we should term it as premature ovarian insufficiency.
Yes. So how
Of
do you
course.
define the primary or the secondary?
Yes, ma'am. So as already shown here, if there are absence of menses by 15 years of age in a girl child who is having the presence of the secondary sexual characters, or if the girl child is not having menses by 13 years of age and no secondary sexual characters are present, then we term it as primary amenorrhea. For secondary amenorrhea, we need to know that a previously normal menstruating woman of reproductive age, if somehow suddenly she has no regular menses or cessation of menses for 3 months, then we should think of we should tag her as a case of secondary amenorrhea.
Yeah. So the age is 13 or 15 years for primary amenorrhea. So we have to investigate early if there is a delayed puberty, no secondary sex characters, then we have to investigate them early. So the coming to the causes of the primary amenorrhea.
Yes, ma'am. Regarding the causes of primary amenorrhea, again, this is very important because the further evaluation and management depends upon that. So the causes can happen when the problem is either in the hypothalamic pituitary axis or if the problem is at the level of the gonads, which is the gonadal lesions and around 30% of cases. And of course, outflow tract abnormalities may also will lead to primary or premature ovarian insufficiency, and around 50% of cases are idiopathic.
Yeah. So you
And when we are going to classify these cases like central causes or gonadal causes, of course, in central causes, it can be due to any CNS lesion, like a functional hypothalamic amenorrhea, hyperprolactinemia, Coleman syndrome are certain central causes, craniopharyngioma, and again, end-organ dysfunction as happens in gonadal dysgenesis, Turner syndrome. All those cases can be there, and outflow tract abnormalities like imperforate hymen, MRKS syndrome, and transverse vaginal septum.
yeah. And the gonadal one, the chromosomal, the Turner,
Yes,
the
ma'am.
46XX gonadal dysgenesis. So how do you approach in your clinical practice, like the
Yes, ma'am. For any clinical case or any medical case, the first and important part is the history. And history in such a child who presents to me with a primary amenorrhea, a history of head trauma or surgery is very important. Or if there is any past history of chemotherapy, radiotherapy, headache, vomiting, and galactorrhea, we need to ask whether to rule out hyperprolactinemia. And of course, cyclical pain with no menses and a bulge in the lower abdomen, we might think of hematocolpos or imperforate hymen. And of course, secondary sexual characters is also very important to decide that what is the Tanner staging, and in that way we can decide the further testing. And of course, as we teach to all our pediatric students and even obstetric students, any girl child presenting with short stature, we should rule out the Turner stigmata like webbing of the neck, increased carrying angle, and then they may have a cardiac abnormalities and widely spaced nipples, and sometimes even a short fourth metacarpal. So short stature is very important. So anthropometry should be done. History of weight loss is also very important, and sometimes even increased weight, like a girl child with Prader-Willi syndrome. She may have a obesity, intellectual disability, and primary amenorrhea. And of course, signs of androgen axis should be checked upon to like hirsutism, hypervirilization. And for central hypogonadotropic hypogonadism, like if the child is presenting with anosmia, headache, then she might be having a Coleman syndrome. Similarly, if the child is having visual impairment, developmental delay, she might be a case of septo-optic dysplasia. So, of course, history and examination is very important.
Yeah. So thank you, Dr. Mayan. And so at first visit, you would do FSH, LH, all biochemical like TSH,
Yes, ma'am.
prolactin, THES, androgen, testosterone, and ultrasound. So
Yes,
just have a baseline to understand that whether there is a hypergonadotrophic, hypogonadotrophic. So in the second visit, we do the karyotype in hypergonadotrophic hypogonadism. We also do karyotype in cases with the absent uterus to diagnose whether we are dealing with the MRKH or whether we are doing with the androgen insensitivity. And if there is hypogonadotrophic hypogonadism, whether there is any central cause to detect any pituitary tumor, pituitary lesion, so MRI or CT scan, and also to detect the 17-OHP to detect the congenital adrenal hyperplasia. So I would like you to explain this, busy slide, Dr. Mayank.
Ma'am, though it looks
Busy, but
busy, but
I'm sure you can simplify.
it is a very important slide which we all should use in our clinical practice when we are getting such a child. You can see very clearly it has been written that first thing we need to see about the secondary sexual characters. If they are present, then of course next step is ultrasound of uterus as was done in the first case. And if it is absent, if the uterus is absent, then we have to do a karyotype, which will help us in differentiating whether it is MRKH or AIS. So very wonderfully shown here. Then if the uterus is present, then of course we are going to think about the outflow tract abnormalities. Suppose if secondary sexual characters are not present, they are absent, we should think about the FSH and LH levels. If they are high, then of course it is a case of hypergonadotropic hypogonadism, as told by madam previously as well. This is also an indication for karyotype. Why? Because it will help us in detecting the Turner syndrome, the mosaics, and other gonadal dysgenesis like XX and XY. Similarly, if it is like a 46XY and premature ovarian failure is happening in a woman, then even a fragile X testing is also important, because historically it has been seen that females with fragile X, the pre-mutation range or the number of repeats, if it is in the pre-mutation range, like less than 200, then around 20% of them may have a premature ovarian insufficiency. And of course, if low FSH LH is there, it is a case of hypogonadotropic hypogonadism. The causes are written here. And in that way, ultimately, if we are suspecting the monogenic causes, we can offer the family a whole exome sequencing.
Yeah, thank you. So thank you, Dr. Mayank, for clearly highlighting the when to order the karyotyping, when to order the Fragile X, and the whole exome sequencing. So the common genetic causes are chromosomal abnormality, which are the Turner syndrome. It can be a mosaic also, and the X autosome translocations. Fragile X pre-mutation carrier they account for about 20% of these carriers. So the monogenic causes.
Ma'am,
When do you
sorry to
suggest
interrupt you.
NGS?
The panel time is over. We're already 6 minutes past the given allotted time, and
I
it is
think
already
we
5
should
p.m.
stop
also.
here. We have already discussed when to offer the NGS, that is the consanguinity, family history, and if the karyotype is normal, whether it is XX or XY, then we can offer the NGS, and syndromic and non-syndromic causes. And I think management part is best left to the obstetrician. There are two main areas here, that induction of puberty by the unopposed estrogen, and the progesterone will be added after 2 years of the continuous estrogen, or when there is a breakthrough bleeding. So when to start at around 12 years of age, which estrogen, they know it better, and it has to be gradually increased. And then maintenance therapy, we generally prefer to give the like the oral contraceptives, but it can again be by the same. So I think we should conclude here, Dr. Manji. We have already discussed about the take-home messages. Hello, am I audible?
Yes, ma'am, you're audible.
Yeah. So do we have 1 minute each for at least 1 to 2 minutes, so that my panelists can, starting with Dr. Vibha. So you have already said that CMA is the first year test in cases of the product of conception, and karyotype for the balanced translocation carrier in the RPL. Then in the fetuses with the abnormality, the microarray is the first year test. Then in the intellectual disability, microarray is again the first year of the test, unless there is a consanguinity. In the primary amenorrhea, of course, we have to check the hypergonadotrophic hypogonadism and the absent uterus. They would need karyotyping. In male infertility, two basic tests, the karyotype and the Y microdeletion, and these are normal. Then, so I think with this we conclude our session. So thank you, everyone, for joining us today. Thank you, Dr. Manjit and Dr. Saurav, for giving us this opportunity. And thank you, Bhavya and Vidu, for helping us in carrying out this webinar.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you so much, ma'am.
My
It was an
panelists
amazing
also. and the speakers. Yeah.
Thank you.
So,
Ma'am,
and
actually,
That's
we
been a
all lost
wonderful
sponsors.
panel, ma'am. Elaborately discussed a lot of things.
Yeah,
Okay.
we all lost track of time until we
Absolutely.
saw that we are already 5 minutes past the panel
No,
time.
I was thinking
So
it will go till 5:30. So I'm happy with my, timing. So you are saying that 5 minutes ahead, and rather I'm happy because I was,
All cases were pertinently discussed, ma'am. And we'll
yes,
have
ma'am.
time for some questions which were put there. Dr.
Yeah, there are
Bhavya.
some questions also, ma'am.
yeah.
So I'll start with the first question, which was actually answered by Dr. Meenakshi also, but I'll just read out the questions for everyone here. So the question was, ma'am, is there a way to screen for psychiatric illnesses in couple who are planning pregnancy, especially if there's a family history of severe mental illness like schizophrenia or bipolar disorder in first degree relatives of the couple? So if Meenakshi ma'am is there, she can directly answer. I'll read her answer here.
You can read. I think she's not.
Okay. So ma'am answered that these are to answer that these are usually multifactorial or polygenic. So if ruled out, they're like monogenic neurological mimickers can be there, and if it is purely schizophrenia or BPD, again being multifactorial, we cannot screen them prenatally. Basically, that is
Yeah,
what
but
ma'am
it's still,
answered.
these are common requests. So I would still offer them, the whole exome sequencing, because these are common indications for coming to us in a reproductive counseling.
Okay, ma'am. Okay, so that's it. Thank you,
Yeah,
ma'am.
we tell them that this is a multifactorial, but as like carrier testing, we are offering, we can offer.
Mm.
So we have started offering this as well.
Okay, thank you.
I
The
had a
next question.
question around here. Like we also read that majority of the couples who have advanced paternal age, they are also at a high risk of developing schizophrenias and autism spectrum
Yes,
disorders.
autism. Yes.
So in that cases, ma'am, we can also evaluate that particular thing or any testing that could be done there.
Yeah, the advanced paternal age, we have to, actually the advanced maternal age and paternal age, that needs a preconception counseling, because the society is changing.
Right.
People are into their profession, so they're not realizing that there is just a very small window for fertility. The rest
Right.
of the life is to work, but for fertility, it is 25 to 35 years for women, and for men, it's less than 40 years. They have to plan the pregnancy. So yes, the advanced maternal age, other autosomal dominant disorder like achondroplasia, the literature does say that they are increased incidence. But so I think that needs a preconception counseling. That is again in itself is a different topic, and we would love to do along with the carrier screening. So
Right, ma'am. Right.
and the preconception counseling is not only for screening for genetic disorders, it's also for the non-genetic. Here we take the opportunity to screen them for the infections, like if she's rubella non-immune, then
Right,
we
ma'am.
can give her vaccinations, varicella. So both genetic and non-genetic preconception counseling, and so this is like a health checkup before pregnancy.
Absolutely.
Yeah, next.
Dr. Bhavya?
Do you have more questions? No.
Yes, ma'am. There was a question. A fetus with a double aortic arch is at risk for 22 deletion. Or in other words, can 22q deletion have any cardiac anomaly? Dr. Hemlata had answered this question, ma'am.
Yes, so we had discussed that if there is any arch anomaly,
Yes.
there's an association with 22q microdeletion. So if there's a right aortic arch, double aortic arch, or an interrupted arch, all of those we specifically like to do the 22q microdeletion. The one thing we didn't cover, Dr. Seema, was that nowadays we have the NIPT also for the
Yes.
22q microdeletion, and there's a recent study published in the AGOG where they have a good sensitivity for the 22q microdeletion using the non-invasive technique. The positive predictive value, I think, in that study was more than 50%. So,
Yes, 30 to 50% they are saying,
yeah, yeah.
but sometimes I feel that they misguide also for 22q deletion. It's best to do the invasive only,
Only
because the
invasive.
size, as we can see, the size is very different. So we are not very sure that how much MB they are able to pick up. Most of the routine micro, the NIPT, they cover maximum 10 MB, 5 MB, and most of the micro deletions will be less than that. So unless the lab is validated, so I think it takes
Uh,
some time, and
Yeah.
the NIPT was still not covering. I think the sensitivity was 85% in that
yeah,
study.
Yeah.
We don't have enough
So,
data from our own practice in terms of the 22q. I think
no,
I've
I
seen
had come across one
one
case that
case
the
in
NIPT had picked up,
case
and that was confirmed also.
Yeah.
But routinely,
But
I
then
don't.
smaller deletions, yeah. I think at least the smaller deletions, the one that like you had presented 720
Yeah,
kb one.
so
No,
it,
that
it
was very
cannot be
tricky to
picked up.
come on
So I feel
NIPT.
that, it should not be offered for that.
True,
But
true.
although they say that the technique is different, so this can be picked up. But till the time it is, we cannot, if there are indications for this, for the 22q deletion in the form of double aortic arch or the interrupted or the right-sided aortic arch, then it's better to go for invasive rather than, if somebody does not opt for invasive because some of them may be IVF precious, then probably yes. Yeah.
We have another question that can a male with Y chromosome microdeletion have his own child by Tesse or something? If he gets a male child, will the child also have the microdeletion? Will he also be infertile?
Yeah.
Yes, they are, yeah. So the thing is, a majority of these Y chromosomal microdeletions are actually infertile. But then, depending upon the extent of deletion, some of them have been known to father spontaneously. Very rare cases, though. But yes, so
Yeah.
if the deletion is quite big, then of course they are infertile altogether. But if the deletion is very small, then they can actually father children. And if they have a
ZFC1.
son,
Yes,
ZFC1
ZFC. Yes, ma'am. So
yes,
as ma'am had showed that diagram,
that diagram.
the AZF region spans segments A, B, and C. If it's
Hmm.
a bigger deletion involving A, B, or A, B, C segments, then of course it could be Sertoli-only syndrome, or it could be severe. It could be
Maturation
azoospermia
arrest.
totally.
Yeah.
Yes, maturation arrest. However, AZF-C deletion, microdeletion, is the one which has the best prognosis in terms of in terms of yield of sperm by doing a TESE or a micro TESE. So here in these subset of patients, you can take them up for sperm retrieval by microsurgical techniques and then go for ICSI. The important point over here is that you have to do this counseling that all the males will inherit this microdeletion and their fertility will be compromised, although there will be variable expression. That means it can range from azoospermia to oligospermia, but the penetrance is 100%. That means all of them will manifest either in a mild way or in a severe way. So in a pedigree, you can have various males inheriting the microdeletion by microdeletion, but variably expressing. The
Yeah,
females
and they
will not
also say,
inherit, and the
it is
females
like,
will are not at
early
risk.
father, young father may not manifest it. It's like
Correct.
menopause, so it's like that. The men
Yes, ma'am.
aging with, yeah. So that is
Yes,
also
ma'am.
said in the,
Yes.
Yeah, it's
However,
limited.
the pregnancy outcome and the live birth rate is comparable to the normal population.
yes,
And
even with
the
the
females will not.
AZFC1. Yes.
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 Yes, ma'am.
Yeah.
So another
Thank you.
question which
Thank
Dr.
you.
Mayanka just put out, can PGT be performed to determine the sex of the fetus in Y chromosome microdeletions?
Of course, it can be.
Yeah.
It
No,
can
it
be in
can be
PGT.
done, but
You
we
can.
don't know.
We don't. It's not to be disclosed under PCP and DT, but it can be done. It is. It. I mean, the lab knows, but you're bound by the rules.
Exactly.
Yeah, this is an ethical question. So I think.
Yeah, I think what he meant was, can you do
Yeah.
it for sex
We
selection?
don't
No,
want to
Correct.
eliminate males. We don't
so I
want to eliminate
remember
them
Yeah.
there
for
was
sure.
one case. So my thesis had a subject. So during my pediatrics, my thesis was on outcome of babies born with assisted reproductive technology. And I remember I had a patient. The husband had undergone ICSI for this very reason, why microdeletion.
Okay.
And so he had fathered a child, and he kept insisting that whether he has a son or a daughter, and we never disclosed that. So it was
Yeah.
PGT case, and we did PGT and everything, and we did not disclose. He had a daughter though. Yeah, so that was the only thing. But then we had counseled him for this. And in any case, I mean, they were ready to go ahead and have a child, considering that the couple was trying for almost 18 years. So they were okay with that part, right?
Yeah.
Yeah.
I mean, the same thing. I had another question that, there are many normospermic men who are also infertile. We cannot just outline with the semen parameter, just the normal seminal examination, semen examination, or also the FSH and the LH values. Majority of the many cases with varicocele patients and other cases also.
Yeah, these are
And
non-genetic
also,
cases. These are
yes,
not
ma'am.
so we who need evaluation by the. But yes, ART is a boon to all of them.
And
Yeah,
also,
because they
ma'am,
are
in the
normogeospermic, so So,
yes, and in WHO 6 manual also it comments on the various extended and advanced, semen examination, oxidative stress, DNA damage, and all these investigations as well.
yeah, so they can
We
help.
come
ART
to
has helped many people to conceive their own children. So that's a big help to many infertile couple.
absolutely. We have one more question. There's a couple with 3 pregnancy losses, first trimester, no workup on any of the abortus or couple. How to proceed and and the couple was non-consanguineous young couple. How to proceed with
Yeah.
this?
So Dr. Biba, are you around? Okay. So, generally we would do the for the recurrent abortion cases. So first we would do the autoimmune causes, like we do the testing for the anticardiolipin, anti-beta 2 glycoprotein, and the lupus. Then we do the biochemical investigations like thyroid and the prolactin. Then we do the anatomical workup by the 3D ultrasound, and then so we also have the karyotype. So this we all do in the first visit. Then in the second visit, suppose some problem is there, then we include the ANA, the sperm DNA fragmentation index. And literature does not support the thrombophilia profile like the factor 5 lead-in and all. But in cases of the recurrent abortions, we generally, as a second visit, we may tend to offer these thrombophilia testing as well. And in the third, suppose after all these coming out to be normal, then at the end we also like to do the bleeding disorders workup. So there are different tiers: first visit, second visit, like that. So this is how the commonly we would do the 3D ultrasound, then the biochemistry like the thyroid and all, and the autoimmune workup and the karyotype. Yeah. So
Okay.
Thank you, ma'am.
Thank you, ma'am. So this is another question. I'm sharing the screen for an MRI. Just 1 minute. Can you see my screen?
no. Yes, now we can see.
Shared in the chat. And the question is that patient has primary amenorrhea, karyotype 46XX, 9QH plus. What next?
So the karyotype is already done, and which is normal, 46XX.
Yeah.
Yeah, and 9QH plus. So definitely 9QH plus is not the. And what about the FSH and LH? So here, like she FSH, and so here I would order the hormonal evaluation, FSH, LH, and estradiol, and would like to see whether she's eugonadotrophic or the hypo or hyper. And depending upon the management would be, so if that again turns out to be normal, then the Fragile X screening, because some of the carriers may have. And suppose the Fragile X is also, then the third visit would be doing the whole exome sequencing. So this is how we go about such women. And of
Okay.
course, the management is the HRT for all, including the hypo and the hyper. Both would require the same HRT, that is the estrogen and the progestogen. So it's not
Yes,
different
ma'am.
for hypo or hyper.
And proper counseling for the patient always.
Yes, all.
Yes, ma'am.
There are
Thank you.
case reports of hypoplastic ovaries being reported in 9QH plus. I think there are 2, 3 case reports like that. So I'm kind of now wondering, are they really, is there really some, because
I'm not sure what is the criteria they are using for
what is the
hypoplastic ovaries.
Yeah,
Yeah.
exactly. Because traditionally
Always you have the tradition. Yeah.
we have always counseled that this is just a heterochromatic and it need not, you need not pay attention to that. But recently offhand, while I was reviewing a literature for one of my patients, I think last year only, I did come across 2 or 3 case reports.
Yeah,
Let's
yeah. They would
I
say even the
will
recurrent abortions, everything is
Yeah.
written in that. But till now we restrict ourselves that this is a
So this
polymorphism
is the
only.
polymorphism.
Yeah.
But I think let's
Because
really
after all,
start
this is
compiling all the
heterochromatic
cases.
only. Yeah.
Yeah, but let's start making let's start compiling our cases itself, that host those N9QH plus who presented as hypoplastic ovaries. I have one case myself, so I'm just wondering, maybe we can really kind of, maybe another thing which is going on, and maybe people are missing that out now. I think so. Maybe another study. I don't know.
Unless we do the NGS, the whole whole exome. We cannot say that, this is because of the 9QH plus. So we'll have to include them in a research study only.
Research study only. Yeah,
Yeah,
that's true.
yeah.
That's true.
Unless we exclude all other causes to put the blame everything on 9QH plus.
I know. Yeah, that's true.
Yeah.
And that will be dangerous, as of
Yeah,
now.
yeah, that will be no. So I think,
Yeah.
So
yeah,
I
Dr.
think we are done with the questions now. Yeah. Dr. Vidhu, over to you.
Thank you, ma'am. Thank you all our panelists and all our faculties for today's webinar. It was really enlightening we discussed nearly all the questions, starting from the obstetrics, the genetic testing in the routine obstetrics to all the pertinent cases as well. We would really like to thank all our faculty for today's webinar and also the participants over here and also for the questions. Manjeet ma'am, we thank everyone from the Indian Society of Prenatal Testing and Therapy, Diagnosis and Therapy as well. Thank you so much. Dr. Manjeet, if you're there, ma'am.
Also, all those who have participated will get the certificates for registration as well. And we urge everyone to join the ISPAT Society and be a member. And be there with advancing technology and the researches that we have been discussing nowadays. Yeah.
Thank you.
Dr. Seema, ma'am, sorry, a little while ago, I just couldn't unmute myself. So admin over here is very strict and he has total control on this. You were amazing. You were simply amazing. All the cases. I mean, you've taken the entire spectrum, from end to end. And different varieties of cases with different testing and different applications. It was a thorough treat. All the panelists have been handpicked so perfectly. Everyone is an expert in their respective field. Thank you so much for this.
My panelists they are themselves there, all experts in their field, and these are all common cases which genetics has learned. So by doing this clinical genetic practice, I have realized you can only do genetic practice if you have a good clinical sense. So everywhere, everything is that you have to have a good clinical sense of when to suspect a genetic disorder. You have to first exclude the non-genetic causes first, and then only you can move on to the genetic disorders. So you have to have a thorough understanding of the genetics, non-genetics, and what are the genomic testing, when to order what. So this is how this is how we can integrate, and this is high time that we all should start incorporating, because genetics has become reached to your doorstep. It has been whether thanks to the commercialization, I'll say thanks only, because that's why made them available to all the masses, so everyone can utilize these genomic testing. So we need to understand them very well. So thank you, Dr. Manjeet and Dr. Saurabh, for providing us this platform.
Thank you, everybody, for a wonderful session, and I think we'll close for the day.
Thank you, sir. Bye.
Thank you. Good night.
Thank you, everybody.
Good night.